Ladies and gentlemen, the program will begin in 5 minutes. Ladies and gentlemen, if you will please take your seats, the program is about to begin.
You muted me? That was probably a good thing. Good morning. How is everyone? Good? He just told me he muted me, and I said that was probably a good thing. How is everybody this morning? Welcome. Too loud? Too loud? Too loud? Too loud? All right, we're going to test this until we get it right. Testing, testing. How are we? Better? Better? All right. Okay, we definitely don't. See, I told you, muted was better. Right? Are we good to go? Okay. So, welcome, everyone, and good morning. Hi. My name is Jennifer Bittner. I'm the CEO with Neuro Challenge Foundation for Parkinson's, and we welcome you to the 9th Annual Parkinson's Expo. Incredible, right? 9 years we've been doing this. I know. Round of applause for that. That's incredible. This is literally a day that we, the staff and volunteers, our board of directors, we get excited about this day every single year. And so we're thrilled that you are here with us today. So thank you for coming out early this morning. We have an absolutely incredible lineup for you, and so I won't take up a whole lot of time because we want to get to all the amazing speakers. We want to give you time to enjoy lots of fun activities today because Steve with drumming, Giving Tree Music follows me, so I know we're all waiting for him. So let's get started. And hello, good morning to all of you who are watching us online through the virtual platform today. Welcome. Thank you for joining us as well. And I always have to sneak this in. A quick little shout out to my daughter Sarah watching from Georgia this morning. And I love to do this part too. So by show of hands, tell me, let me see the folks who are here from Sarasota this morning. All right, there's a good group. More, all right, how about Pinellas County? All right, there's some Pinellas. How about Charlotte County? Charlotte, a little bit. All right, Manatee. There we go. How about Highlands? There's Polk County. All right. Hello. Good to see you guys. I just saw them. How about Marion County? Anywhere else? All right. Thank you. Thank you for coming in from all over the state of Florida this morning. We're thrilled that you're here. So we are excited to be celebrating our 18th year in supporting the Parkinson's community. We would not be here without the generosity of all of the donors and sponsors that make these events possible. So let's give a big round of applause to our presenting sponsor, Amneal Pharmaceuticals. Vahid and his team in the back over there, thank you all so very, very much. And to our Hope sponsors, Acadia Pharmaceuticals and Supernus Pharmaceuticals. Round of applause for those folks, please. And our empowerment sponsors, AbbVie and Observer Media Group. Thank you. And to all of our impact sponsors and our community resource partners. Ladies and gentlemen, we had to cut off and turn folks away. We have sold out the community resource partners today. First time ever. Over 55 different groups for you to be able to visit with today. First time ever. We're so excited about that. I want to give a special shout out to our friends at Encompass Health Rehabilitation Hospital of Sarasota. They were the very first sponsor of the very first Expo. Our friends at Encompass, thank you so much. And a big shout out to our friends and partners at Sarasota Memorial Healthcare System. Carrie and her team that are over there doing the cycling demo for you, they have been partners with us for over 15 years. So we appreciate that support. I want to take this time to thank my entire team and all the volunteers who worked tirelessly to make today happen. So Danita, April, Tracy, Diane, Margaret Ann, Lisa, Sue, Leslie. Big round of applause for the staff and all the volunteers. And at this time, I'm going to introduce my co-host for the day, our newest staff member joining our growing team, Leah Barber. Leah is going to be discussing a little bit later a new initiative, but right now I welcome Leah to join me.
Thank you. Thank you so much, everyone. Good morning. It is such an honor and a privilege to be co-hosting with our fearless leader, Jennifer Bittner, today. So she just, can you hear me? Okay, so I said thank you so much. It's an honor to be here co-hosting. I want to shout out to Jennifer. She just shouted out to the entire team. But I have known Jennifer Bittner for over 20 years, and it's been amazing to join her and see how she has blossomed into such an amazing leader. She is a fearless leader behind the scenes, day and night, making this organization run. So thank you to Jennifer for all that you do. And I am so excited to be part of all of this. So as you heard, we have an amazing, exciting day in store for you with an amazing lineup of speakers as well as special breakout sessions. We're hoping that you can be here for the entire day to hear all of the great presentations, including Dr. Ray Dorsey. He will be speaking after lunch. He is also signing books. He is back there. Please make sure that you have an opportunity to stop by and get your book signed, the Parkinson's Plan, and also to have a chance to speak with him. And while you're here today, please stop by the Talkback booth also to share your experience on camera with us, and make sure to snap some great photos at the photo booth. All of that is happening over there next to our Neuro Challenge booth. And also, please post your photos, and we're using hashtag Parkinson's Expo on your social media sites. So also, shout out, she said, to Sarah, who I've also known since she was little. I couldn't help it. Hi, Sarah, and everybody that's, I had to, and everybody that's tuning in virtually from home. Thank you so much. I hope everyone has a wonderful time.
Okay, so now let's really get this party started. Steve, want to join me on stage? In case you didn't know, drumming stimulates the brain with hand-eye coordination and enabling rhythmic expression and improvisation. Drumming's also been found to reduce stress levels, help relaxation, reduce tension, and promote enjoyment. So let's grab those boom whackers and make some noise and get ready for Steve with Giving Tree music.
Let me hear you. Let me hear you. Come on. Louder. Louder. Bring it. Bring it. Bring it. And hey. Yep. Good morning, everybody. My name is Steve. Say hello, Steve. Excellent. Everybody, please tell me your name right now. Go. Excellent to meet you. This is my lovely wife, Paisley. Say hi, Paisley. And we're here to have a really good time with you guys. You all have something called a boom whacker. Pick your boom whacker up. Hold it up in the air. Let me see you say, yeehaw. Yeah, exactly. So you put your boom whacker in your main hand, the one you like to write with, throw a ball with. Take that boom whacker, put your other hand up in the air. And let me see you go. Amazing. Let me see you do it again. Let me see you go. That's called a rumble, right? And stop. Rumble if this is your first time at the Neuro Challenge Parkinson's. Well, it's not mine, actually. Makes me laugh. Great job, first time. What about your second time? 2 or more. 3. Fourth. 5th. 6th. Oh, there's the drop. 7th. Okay. 8th. Okay. 9th. Who came to the first one? Anybody? There it is right there. Rumble if you're ready to have some fun with me today. Perfect. Now, I want you to take these boom whackers and hold them up in the air for me again. I'm going to teach you about the 2 main sounds on the boom whacker. I taught you about the boom whack. Let me hear a boom whack. Amazing. Let me hear another boom whack. Let me hear 2 boom whacks. Let me hear 3 boom whacks. Perfect. Now, that's the one sound you got a boom whack. The other sound is called a boom whoops. Let me see the boom whoops. Yeah, there you go. Let me hear 1 whack, 1 whoops. Whoops. Look at us. What about 2 and 2? Nice. 3 and 3? Nice, and stop. Now, if you've noticed, hold your boom whacker up, look around. There are a whole bunch of different colors here. Each one of these is a different note. So let me hear the big, long red ones, the big reds. Let me hear orange, yellow, green, purple, little reds. I love that sound. That's my favorite. I know it's cute. All right. Let's try again. Just one time this time. So 1 hit. Yeah, that's pretty nice. Let's do it again. So that's bottom to top. That's pretty good. Let me hear the big reds. Orange, yellow, green, purple, small red. Let's build it again from the bottom to the top. Big. Feel it? Mm-hmm. We got my girl happening, right? I got sunshine on a cloudy day. When it's hot outside, I come to the Parkinson's Expo in March. Give me a big old round of applause. Come on. Big. And Paisley, how about a nice little groove? There we go. Let me see y'all feel that for me. Got to move your body a little. Paisley's a pretty good drummer. She's going to help it groove for you. Everybody, one time. What about 2 times? 1, 2. 3 times. Here we go. Little faster though. 3 times. Go. 5 times. 9 times. All my big reds, are you ready? We're going to build a song. All the big reds, starting with you. Say, wait. Big reds, are you ready? That's your only part. Can you keep it? Can you keep it? Big reds. Hold on to that. Big reds. Little reds, we're going to answer them. Watch. Ah, my bad. Bump, bump, bump. Let's keep that. Come on, little reds. Big red. Boom, boom, boom. There it is. Yellow, orange, I mean. Ready? Keep going where you're at. Keep going. Orange, say. Keep going, keep going. Yep. Yellows. Good job. Greens. Oh, hold on to it. Say. Nice and loud, nice and loud. Purples. Here we go. Say. Purple. Here we go. Keep it going. That sounds really good. Nice and loud, nice and loud. 4, 3, 2, 1, stop. 2, do it again. Go. All right, let's try it. 4, 3, 2, 1, echo me. I'll go first, like this. Listen up, say. So close. That was really good. That was really good. Those are like the words, talk with your hands. 1, 2, make it up. Let's go. Up high, up high. Keep going, keep going. Ooh, y'all sound good. You guys right here, keep going, keep going. Don't quit. I'm going to talk to them for a minute. Keep going over here, right? Over here. 4, 3, 2, 1, stop. Give them a round of applause. They sound nice. Don't quit on me. You're the band now. Y'all echo me. Keep going. Say. They sound great. One, two, come on back, everybody. Go. All right. It's their turn to hold on. Y'all keep playing for me. Don't stop. Don't stop. Keep it going. Keep it going. Yep. 4, 3, 2, 1. Ho. Give them a round of applause now. Everybody, let me hear you rumble on that thing. Rumble on that thing. Louder. 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 And ho. Here we go. Do it again. Yep. 1, 2, 3, 4. Whoop. 1, 2, 3, 4. Whoop. One more time. Here we go. 1, 2, 3, 4, 5, 6. Come on back. Go. That's where we were. Here we go. 4, 3, 2, 1, stop. Let's go a little bit faster. All my reds, big reds, keep going. Everybody else. 4, 3, just big red. Let me hear the orange. And yellow, and green. Let me hear purple. 4, 3, And, yep, and, yep, Before you give yourselves a round of applause, let me hear you rumble if you're one of our caregivers today. Give them a round of applause. Let me hear you rumble if you're in orange and you helped put this together, especially April. You did a lot. And let me hear you rumble if you're living with Parkinson's. We're here for you guys, that's right. Everybody, one more big rumble. And stop. Tell your neighbor thank you. Tell your neighbor they sounded great. Now tell your neighbor how great you sounded. Say, I sound great. Say, I sound amazing. Say, I look good too. Thank you guys so much for sharing space with me, you guys. Thank you, Paisley.
So I know we're ready to go for today now, right? That was awesome, you guys. Give yourselves a round of applause. Okay, so we are going to get ready for two things. We not only have Dr. Dean Sutherland speaking here from the main stage, but we have our very first breakout session this morning that's sponsored by Acadia Pharmaceuticals for Care Partners in the Longboat Key Room. So if you would like to go listen to Dr. Martha McGraw, a special presentation brought to us by Acadia on hallucinations, then you can make your way to the Longboat Key Room, so just on the other side of the exhibitors and onto that side of the conference space. The Longboat Key Room is set up. They will welcome you over there. We're happy to assist you if you need some help. So we're going to have the Care Partner Room and that presentation going on in the Longboat Key Room, and then also Dr. Dean Sutherland here on the main stage. I think we need to give our volunteers just a minute or two to collect the boom whackers. Thank you again to all the volunteers who are here today to help make today possible. There were a bunch of volunteers here with us yesterday as we were setting up and packing bags and getting ready for all of you to come out today. So we appreciate all the folks that helped make today possible. Absolutely. Big round of applause for those volunteers. We appreciate that. All right, I think we're doing pretty good with collecting the boom whackers. Look good? All right, we've got some folks that are headed over to the Care Partner presentation. Yep, we'll see you back in just a little bit. Somebody's waving at me back there. We'll see you back in just a little bit. All right, fantastic. Well, now it is my honor to introduce our first speaker this morning from the main stage, Dr. Dean Sutherland. Dr. Sutherland is a neurologist with Sarasota Memorial Healthcare System and is one of the founders of Neuro Challenge Foundation. His presentation will include information for those newly diagnosed with Parkinson's disease. So please, put your hands together and let's give a warm, warm Neuro Challenge welcome to Dr. Dean Sutherland. To give you a hug.
Thank you, Jennifer.
Whoops, I'm sorry.
Thank you, Jennifer. And thank you, all you special people, wonderful people for showing up here today, and the volunteers and our great sponsors that we have. We're so feel so honored to have you all here. So Jennifer and the Neuro Challenge team asked me to talk about Parkinson's for the newly diagnosed. So instead of just doing my usual presentation I've done over the years, I thought, why don't I talk about the things that patients come and ask me when they first meet me, when they first are diagnosed with Parkinson's. Has anybody here been diagnosed in the last 2 years with Parkinson's? If you could raise your hands. Okay. How about 1 year? Anybody within the last 1 year? Okay, there's a few people here. All right. So you have a slide advancer here, yes? Oh, wait. Maybe I need to point this somewhere. Okay. All right, so if we can go to the next slide then. So just as disclosure, I am a speaker for AbbVie and Amneal. It says Anneal there, but it's Amneal. Go to the next slide, please. Okay, so this picture here, I just want to let you know, this is Bob. This is not Alan Alda. It looks totally like Alan Alda, but it's actually, we're calling him Bob. Okay, so next slide, please. So Bob is about 70 years old, and he came in to see me with a tremor in one hand. If we can go to the next slide. And so the tremor had started 3 years earlier and was getting slowly worse. He goes to his primary doctor, and the doctor says, well, you probably have this different type of tremor called essential tremor. And that's a very common scenario. People get misdiagnosed initially. We all do this as neurologists. Even, in the best of hands, it can be seen as essential tremor. He tries a couple of his tremor medications, and it doesn't really help, so his doctor says, well, maybe we should now send you to see a neurologist. So he goes to the neurologist, and the neurologist sees him and does a good job, but it's a brief interaction, sees him for about 5 minutes. And after examination and talking to Bob, he says, I think you've got Parkinson's disease, and here's this prescription for a medication. You take this, and we'll see you back in about 6 months or a year, and sends him out the door. And Bob is just blown away. He comes out into the door, and he says, what just happened? That was crazy. Okay, next slide, please. So when you first get a diagnosis, there's a number of emotions that you probably remember feeling. It's confusing. It's scary. People can feel very disoriented. What is my life like? What am I going to do now? Depression can be a big problem. So if you're taking a multiple choice quiz here, it would be all of the above, I think, for a lot of people. Next slide. So what is Parkinson's? Well, we call it a movement disorder that is slowly progressive. It happens over many, many years. And in fact, as we'll talk about in a minute, it happens probably 5 or 10 years before you even start to get a tremor. It affects your brain and your gut function as well. And it probably comes mainly from the environment. We'll talk about that a little bit, and Dr. Dorsey will be here later, and he'll talk about that as well. And it's caused by a loss of dopamine neurons in your brain. And what the result is, the things that we see on the outside are slowness of movement, tremor, balance problems, and stiff muscles. Next slide, please. So this representation of a patient with Parkinson's includes all the things you can see on the outside. So people tend to have a stooped posture. They tend to walk slowly, move slowly. Tremor is one of the things that's easiest to notice. When you're walking through the mall, you see someone with a tremor. That might be a Parkinson's patient. And then usually the stooped posture with the legs kind of bent, shuffling gait, decreased facial expression, soft voice volume. A lot of times people will come in and they'll say, well, my wife told me I'm not moving my right arm. It's not moving at all. And that can be the tip-off for some people as well. Next slide, please. But Parkinson's is really kind of like, we think of it as like an iceberg. Those are the things you see on the outside. You see the tremor and the stiffness and the posture problems. But in fact, there's a lot of other things going on underneath the surface. And those things probably in the long run present more of a problem. Cognitive issues, constipation, speech and language problems, concentration, memory. People tend to have blood pressure drops. They tend to get sweating episodes. Dementia can set in with hallucinations. A lot of patients have ED, erectile dysfunction. Some patients on some medications get abnormal behaviors we call impulse control problems. And those are very significant, and they can cause a lot of problems. So those are things your doctor really should talk to you about. Next slide, please. Okay, so dopamine. So there's probably 40 neurotransmitters in the human brain, of which dopamine was probably one of the first ones discovered. And dopamine is really the thing that we're concentrating on when we're talking about Parkinson's. So in this representation, you can see one cell has these little globules in it, and the little blue dots, those are dopamine granules, and those are getting sent across to the opposite cell, which has the receptors on it. And then on the first cell, there's also these little blue channels, and that takes dopamine back up into the first cell. So those are all places where we know that we can affect Parkinson's disease. We can try to give you more dopamine, or we can affect the reuptake of the dopamine. And so there's a lot of little targets right there. Next slide, please. So probably 220, 30 years ago, there was a couple of doctors who noticed that there was some dark matter inside the brainstem, and they didn't know what it was. And then in the early 1900s, people started looking into this more, and around the 1950s, we figured out that that black stuff in there was probably dopamine. And those cells that are there are in a place called the substantia nigra. So the substantia nigra makes this dopamine. And this control section here on the left, this is a person that has normal darkly staining. Actually, you don't even have to stain it. It just shows up dark in the brain. I've been teaching neuroanatomy for 40 years or so, and we cut up human brains in the lab, and you can see patients have this. Every patient has this, except for Parkinson's patients. So the one on the right, you can see is kind of bleached out, and that's the way it actually looks on a Parkinson's patient's brain. So they're not making dopamine in the substantia nigra anymore. Next slide. So what happens? Why does that cause a problem? Well, in the normal neuron situation, it's releasing dopamine throughout the brain all day long, and it's kind of like, it's like a river flowing. It's not like a burst of dopamine. It's actually more like a river, and there's a little rheostat like you have on your stereo, and it turns it up or down, depending on what you need. But in Parkinson's, you don't have the ability to do that anymore. No matter how much you try to move the little rheostat, your dopamine is not going to get released, and it causes an imbalance in the whole chemical system, which is why people get the problems of stiffness and tremor and things like that. So we want to restore that if possible. Next slide. Why do these dopamine neurons die? We have some pretty good indicators, just like in any part of science. A lot of times we don't know exactly, but we have some pretty good indicators that that there's a problem with a protein called alpha-synuclein. We know this very well, and it misfolds. There's a normal alpha-synuclein which helps with your cell function, but sometimes that gets fouled up. And then when it gets fouled up, it misfolds and forms these, what we call oligomers. And then those group together and form these fibrils. And inside the neuron, that messes up the whole mechanism for the neuron functioning. A neuron has to be able to move things around, has to be able to produce things, it has to be able to remodel itself. And when you get this protein that builds up in the cell, it can't do that anymore. It's like a huge traffic jam. And then eventually, the cell forms this thing called a Lewy body. You guys have probably all heard of, if you've had Parkinson's or looked into it, Lewy body is, there's a dementia called Lewy body. This is not that. This is these little globs that are inside the cell that eventually Lewy body dementia was named after, but Lewy bodies are really globs of protein in the cell. Can I get the next slide, please? Okay, so here's a series of what we call micrographs, or little pictures through the microscope. On the left upper panel, you see these blue dots, and that is alpha-synuclein, which is clumped up a little bit. And then over on the right side, it's formed this fibril, and then down on the lower left, you see the fibrils are getting longer, and then eventually they clump together and they form this thing in the middle here, this orange blob, and that's a Lewy body. And that is the part, once it gets to that stage, that's a lot of bad protein built up in the cell. Next slide, please. So one of the things that patients often ask me when I come in is there a test? Why can't I find out right now if I have Parkinson's disease? They feel like it's ridiculous. They go to see the neurologist, and we can't give you an answer. We kind of hem and haw, and we say, oh, I'm not sure, This happens very frequently. So do we have objective tests for Parkinson's? Yes, we do, but they're not as good as we would like for them to be. And we'll talk about that in a little bit. Also, once you get an abnormal test, does that tell the neurologist what to do about it? It really doesn't. It's really more a matter of kind of figuring out who you are, what you look like, what are the things in your life, how we're going to approach this with you. Next slide. So we do have one test. It's called a DAT scan. This has been out for, 15 odd years. And on the left, you can see that with this DAT scan, these little bright blobs there that kind of show up, they look like commas. That is dopamine being produced in the brain. And then on the right, the abnormal one is these little small blobs, okay? So you can look at that from where you are, and not being a neurologist, you can say, oh, that's a patient with Parkinson's disease, right? No. So we can't tell by looking at that scan if you have Parkinson's disease. All we can say is it's abnormal. And so it's kind of one little piece of the puzzle. Next slide, please. So if you look at results from studies with DAT scan, it looks really very good. In studies, it's true that it looks like it's very sensitive and specific. So if you have an abnormal DAT scan, you have Parkinson's or something like it. That is usually not the way it is in reality. In reality, there's different facilities that do these scans. They're read in different ways, and it doesn't always turn out that way. So that scan it's a little piece of the puzzle. It's not actually that diagnostic in many cases. Next slide. There's another thing that's come out. It's called a skin biopsy. It's SIN1 skin biopsy, and what we do is we take biopsies from 3 different sites in your body, on the back of the legs and then the back of the neck. And based on the way that those things look, if there's bad alpha-synuclein in those biopsies, then it can tell you whether or not you have predisposition to having Parkinson's. Again, it doesn't tell you if you have Parkinson's or anything like it. It just says you have an abnormal test. Next slide. So if you look at the studies, it looks pretty good. It looks like 95, 96% to tell you what you have with this skin biopsy. But in practice, in reality, it's not that high. Next slide. So when do we use these tests? Well, when the clinical picture is atypical, like let's say you come in and you don't have a tremor, but you have Parkinsonism. You look like you have Parkinson's. Or we put you on medications and nothing happens. It doesn't help you. So then we might start scratching our head and go, okay, what else can we do to try to figure this out? And what are one of these tests? If there's other unusual symptoms like loss of bladder control, loss of blood pressure, hallucinations happening early on, then sometimes we'll use these tests as well. Next slide. So what about MRIs? Everybody knows about, probably most people in this room have had an MRI, myself included. So MRI, shouldn't that be able to tell you if you have Parkinson's? It's so specific. It's such a great picture. The answer is no, it really does not tell us if you have Parkinson's. But it does rule out other things like strokes or brain tumors or too much pressure inside the brain. Brainwave testing with EEG is not helpful. Blood test, well, you can say you have abnormal alpha-synuclein in the blood test, yes, but does that tell you if you have Parkinson's? No. Same is true for spinal fluid or spinal tap. You can say it's abnormal, but again, it doesn't tell you if you have Parkinson's. Some doctors will use what's called a dopamine challenge test. When you go to the office, they'll say, oh, I think you have Parkinson's. Let's give you a couple pills. Come back in 20 minutes and see how you look. That test is not that reliable. It really is. It's not kind of encouraged because it's often, not that useful. One of the things with technology, with all these smartwatches, is that there's programs out there that they're developing that maybe you could tell if you have Parkinson's by wearing a watch on one or both wrists, based on the type of tremor you have and things like that. So I think technology is coming along pretty well to help us kind of figure these things out better. But again, those will be little pieces of the puzzle. It's not, saying, okay, you clearly have Parkinson's. Next slide. Do I really have Parkinson's? I get asked this very frequently. And frequently I'll say, I'm not sure, but I think so. Because it's a difficult diagnosis to make, even in the best of hands. If you have doctors that have been doing this for 25 years, we can't tell you exactly every single time we see a patient if they have Parkinson's. But we will look at you, we'll examine you, look at your results. And then usually what will happen is if we think you have Parkinson's, we'll put you on some medication. 90% of people who have bona fide Parkinson's will get better with those medications. 10% will not. But what's interesting is after a period of time, maybe 5 years, half of those 10% will then become responsive to the medication. But after all is said and done, we're only about 75% at diagnosing Parkinson's, so not that great. Next slide. A lot of patients get told they have Parkinsonism. Has anybody been told that in here? Parkinsonism? So it's actually really common to be told that. And that is not the same as having Parkinson's disease necessarily. It's more like a subcategory of Parkinson's disease is a subcategory of Parkinsonism. So if your diagnosis is unclear, you don't have a tremor, maybe you're not responding to medications, then we may tell you have Parkinsonism. Next slide. So what causes that? Well, we know, as I mentioned before, little strokes, mini strokes all over the brain. If you have brain bleeding, if you've had brain tumor. There's a few things that look like Parkinson's but are a little different and have different side effects, including Lewy body dementia that we mentioned. There's a couple more rare ones, PSP, MSA, and CBD, and then frontotemporal dementia. Severe depression can make people look like they have Parkinson's. Head injuries, advanced Alzheimer's disease, advanced Huntington's disease, Lou Gehrig's disease. So those things can all show up like Parkinson's. Next slide. So advanced age. So interestingly, there was a study that was done in Chicago, I think about Dr. Getz, who had looked at 95-year-olds in Chicago and looking at Parkinsonism. 13% of people at age 95 qualified as having Parkinsonism. So we know it's an age-related disease to get Parkinson's. Also, Parkinsonism is kind of similar in that fashion. Increased pressure inside the brain, which is normal pressure hydrocephalus. You've heard of this. This is one of those things in the news you see every now and then, because it's treatable with putting a little shunt in the brain. So those people have a syndrome we teach our medical students. It's called wet, wacky, and wobbly. So they lose control of their bladder, they start to have some dementia symptoms, and then they have balance problems. And they have a very specific walking pattern that we can see as well. Multiple sclerosis over time can make you look like you have Parkinson's. And then finally, a tremor could be called Parkinsonism. So if you just have a resting tremor or an intention tremor, you could, technically call that Parkinsonism. Next slide. Are there treatments? Yes, yes, and yes. I want to make sure that people know that, because a lot of times people will come in and I'll tell them that I think they have Parkinson's, and they'll say, but there's no treatments for that, is there? Well, 50 years ago, actually a lot longer than that now. 75 years ago, there was not Parkinson's treatment, but in the 60s, levodopa was developed, and now we have a lot of treatments. Next slide. So first is exercise, the second treatment is exercise, and the third is exercise, as I'm sure you've heard me say before. And that's very true. It probably slows down the disease. Rehabilitation with PT, OT, and speech therapy, those are good treatments. Being here and getting information is very, very important, because as I mentioned, there's a lot of fear, and lack of information with Parkinson's can cause a lot of that. And once you get information, I think at first it's scary, because people tell you you're going to get it worse, but over time it's actually very helpful. We have 23 different pills now for Parkinson's. There's a patch that you can put on your skin once a day, so that's helpful. Kind of releases the medication very slowly over time. There's an inhaler, which can be used, like if you're having downtime in between your medications, you can use this levodopa inhaler that can help you out. Next slide. There is a subcutaneous injection that's been available for a while, so you're starting to have a downtime, and usually it's your spouse that would help you do this, or caregiver, and give yourself a little injection, and it kind of gives you a bump, and you can get yourself moving again. There's a gel that can be put in through a tube in the stomach, and it's called a PEG-J tube. And that allows you to release the medication slowly throughout the entire day. There are 2 subcutaneous infusions that we have, which are little patches that have a tube and then a little fanny pack with a motor on it that pushes a syringe and pushes medication underneath your skin all day long. That's also something newer within the last year and a half or so that's been useful. And then deep brain stimulation surgery. So deep brain stimulation surgery has been out for 25 years or so now, long time, and is very useful in some selected cases. It's not for everybody. But in those people that really need it, it can really make a huge difference in your lives. It can be a real turnaround. And then finally, MRI-guided focused ultrasound, which we don't do here locally, but is done in different places around the country, including at Tampa, University of South Florida. That's where we take sound waves and heat up part of the brain, and it makes a little tiny lesion spot in the brain. And when that happens, it improves tremor and stiffness and things like that. So those are just some of the kind of summary of what we have available. So there are lots of treatments out there available for you. You're not left with nothing. So I've been doing this for 25 years or so myself, and as I mentioned, when I first started, there really was not that many treatments, and I'm very happy to see now that there's just so many things that are available, because it's changed the whole landscape. Next slide. So traditional medications you're going to hear about, if this is something that's new to you, levodopa, we mentioned, gets converted into dopamine in your brain. So it's a kind of a natural substance, basically, because it's going to convert it into dopamine that you're missing. Dopamine agonists, which I call fake dopamine, but basically what that means is that it stimulates your brain the same way that dopamine does. There are 2 enzymes that we use to block the breakdown of dopamine in your brain, so it stays around longer, like it stays around 15-20% longer. So the benefit of that is that you have less of these off times in between your medication. There's a drug called amantadine, which originally was developed to keep people from getting influenza. We discovered by accident that it actually helps people with Parkinson's, specifically if they have something called dyskinesia, but also if they're having off times in between medications. Next slide. So what are the names of these things? Well, Cinemet is probably the one you'll hear the most. Carbidopa-levodopa has been out for 60-odd years. It has two components in here, and this is kind of interesting. So when levodopa first came out, it helped people's Parkinson's. They got better, and it was dramatic, and it was a wonderful thing. And then they also would take this medication and vomit. So there was a team that just figured out if they put carbidopa in there, that it would keep people from vomiting. And if you know any Latin, sin-emet means no vomiting. Cinemet, okay? So that's why the carbidopa is in there. It doesn't get into your brain and do anything. It just keeps the nausea down and the peripheral side effects of the levodopa. Amantadine we mentioned, Requip and Mirapex, ropinirole and pramipexole. Those are dopamine agonists. I mentioned this patch. It's called Nupro or rotigotine. There's another enzyme blocker. It's called rasagiline or Azilect. It's been out for many years. Eldepril, been out even longer than that, or selegiline. Apokin is the subcutaneous injection I was talking about. Entacapone is one of the enzyme blockers. Another one? Next slide, please. But some of the newer things that have come out, one is this inhaler that I mentioned. It's called Embrija. And there's the pump that I mentioned is called Duopa. That's the little gel that goes into your intestines. There's a drug called Nuplazid or pimavanserin, which helps with hallucinations with Parkinson's. There's a drug called Norians or istradafilin, which helps with the on time to give you stretch out your good on time that you have with the medicine. Gocovri also does the same sort of thing, stretching out the on time. Samantadine in an extended release form reduces your side effects of dyskinesia or abnormal movement. Next slide. Rytari. So Rytari has been out for quite some time now and is an extended release form of carbidopa-levodopa. And it comes in different strengths, and it allows you to have more on time in between the medicine. So that's one of the problems you're going to experience if you have Parkinson's just in the last couple of years and you're taking these medications. You will find that there is a time in between the medication administration where you kind of start to feel down and you have to take a pill to get out of that. So a lot of these medications nowadays are improvements on the original carbidopa-levodopa because they are allowing us to give you more on time. And we call that what's called good on time. In other words, not having a lot of dyskinesia. So a lot of these formulations are helping with that. Dehyvi is a Cinemet or carbidopa-levodopa form that has these little quarters, so you can actually break it up into a quarter of a tablet, much easier than using a pill splitter. As I'm sure you guys have experienced, if you've ever tried to split pills, especially if they have a hard little covering on the outside, a lot of times they'll just kind of shatter and go all over the place, and that's very, it's hard to get a good, quarter of a dose with those for sure. But with Dehyvi, it's much easier. You can kind of snap it off. Xadago is another enzyme blocker that gives you more on time. Ongentys, another enzyme blocker, again, more on time. Crexont is a drug you're going to hear more about with Dr. Hauser, which it's carbidopa-levodopa extended release form, also gives you more on time in between pills. Onapgo is a subcutaneous infusion, and Vyalev is a subcutaneous infusion as well. They're different chemicals, but those are the ones that get pumped into your system, 24 hours a day. They give you that steady on time. Okay, so another question people ask me is, why do I even have to take a medicine? Do I really have to do that? And we'll have a discussion about that, and I don't necessarily start people on a medication the minute I meet them. Sometimes I do. It just depends on the person, but what does it do for you? Well, it relieves the Parkinson's symptoms, stiffness, tremor. Those things tend to improve, soft voice, trouble with handwriting and eating. Some people get a better golf score. Walking speed, posture, facial expression, those things improve. And interestingly, we have done studies where we've waited to give people the medication and to see what happens to them. We want to know, are we actually doing them any favors by starting them on medications earlier versus later? And the studies are pretty interesting because what they show is that people who take these medications tend to live longer. They tend to be more functional over time. And if you wait too long to start them, you can't bounce back up to where you should be. So that's the key, is trying to figure out what is that time. So if someone comes in when they have a little tremor in their hand and nothing else, we will not necessarily put them on Parkinson's medications. A lot of times we will do what's called conservative medicine or watching and waiting, and bring them back in 3 months, 6 months, a year, and see what's going on. Once it starts to affect your life, or we feel that you are significantly debilitated, then we will offer you medication. So if you're waiting to start the medication because you think there's some magic window that you can start the medication and you have this 10-year window, that's not really the way it works. So you need to talk to your doctor about really when the best time to start is for yourself as an individual. Next slide. Okay, so common side effects we see with these medications, and this is kind of group side effects. This is not any particular medication we're talking about, but nausea, drops in blood pressure which cause dizziness, extra sleepiness. I have one lady who told me that the ratio those that the light has changed as people are honking behind her in her car. So we had to adjust her medication because she was having sudden sleepiness, and that can be a problem with driving. It really can be. Constipation is very common with Parkinson's and gets worse with the medication. Hallucinations also very common as time goes by. So by 15 years, a lot of people will have little tiny hallucinations, seeing something off to the side, but sometimes it gets worse and they have hallucinations of people in the house, things like that. They're rarely ever threatening. They're usually kind of friendly. After about 10 years, 90% of people will have a little bit of extra movement or a lot of extra movement, and that's called dyskinesia. That's like Michael J. Fox. When you see him on TV, you see him wiggling around. That's called dyskinesia. Swollen red legs can happen with some of these meds. I mentioned impulse control problems. So that's buying, gambling, collecting, sex. Buying a $2 lottery ticket once a week that's not a problem. Buying $1,000 worth of lottery tickets, a week, that's a problem. And we do see this in some people. It depends on things like, younger men tend to have these problems. They do things that are out of character. So if it's something that's out of character or way beyond what normally you should do, or it's bothering your spouse or your family, then that's an indicator that the medication is going to need to be changed. Next slide. Okay, so who's in the treatment team here? Well, you have your primary doctor. That's your goalkeeper, right, or your gatekeeper, and that's really should be kind of sending you to specialists, and including the neurologists. The general neurologist can diagnose and treat Parkinson's disease. Once it starts to become a little bit more complicated, or if the diagnosis is unclear, sometimes they'll send you to a movement disorders specialist, which is a subspecialist type of neurologist. If you need brain surgery, of course, the neurosurgeon will get involved. Psychologist, very important. 30 to 50% of people who have Parkinson's get depression and anxiety that they did not have before. It's chemical, right? Dopamine makes you happy. If you're not getting enough dopamine, you have a chemical problem, you're going to wind up having some mood disorders there. Psychiatrists, same sort of idea. Psychiatrists are mainly prescribing medication nowadays. The old model, the Woody Allen, you go and lay on the couch and the psychiatrist talks to you for an hour and, oh, time's up, get out. It's not like that anymore. Really, so the psychologist is more the person who is treating you with talk therapy and things like that, whereas psychiatrists are more like neurochemists, and helping out with medications. Social worker in this situation, very, very important. And also local and national resources, which we'll talk about in a little bit. Very, very important to get involved in that. And what I didn't put on here, I failed to put on here, is the treatment team includes your spouse, your caregiver, your family, your neighbors, the people around you. I call Parkinson's a whole body disease because it involves a lot of things, but it also is more like a community disease, because it involves a lot of people around you that are affected by it and can help you. Next slide. Okay, is there any cure? I get to ask this pretty frequently. Usually as people are leaving, or I'm leaving the room, or they're leaving the room, they'll kind of be walking out and go, oh, by the way, is there any cure for Parkinson's you haven't told me about? So the short answer is not so far, but we are working on a lot of things, and I will say that the medications and the treatments are coming out faster and faster, and we are working on towards something that will probably slow or stop the disease as much as possible. I don't think we'll be able to turn the clock back 20 years or cure it per se, but I do think that we're going to come up with something that will slow it down more than just exercise. So that's, I think, is something to look forward to. Next slide. Another thing people worry about is whether or not their kids are going to get Parkinson's disease. Well, probably not unless more people in your family have it. So If it's just you, it's probably not a really increased risk for them. But if it's you and your father that had it, or you and your brother or something like that, then that does increase their risk a little bit. Most Parkinson's is actually environmental, and just maybe 5 or 10% is genetic. And I think Dr. Dorsey's going to talk a little bit about that more, but my understanding is that most of it really is probably environmental, things like herbicides, pesticides, fungicides, cleaning solutions, printing industry. So there's a lot of risk factors there. So if you're the only person with Parkinson's, then probably I don't think your kid's risk goes up significantly. But in certain small populations like Ashkenazi, Jewish populations, Berbers, which are some of the people around the Mediterranean basin, and the Basques, which are in northern Spain. So those communities have a higher risk for this one gene that's associated with it, you'll probably hear about later on. It's called LRRK2. Next slide. Another thing people ask me is, what is my life going to be like? It's a slowly progressing disease over 15 to 20 years, as I mentioned. So you will need more help over time. But the things that will definitely make it worse, we know, is if you don't take care of your other medical problems, if you have diabetes that's out of control, if you're not taking care of your heart problems, if you have a history of cancer and you're on chemotherapy and things that are really going to over-affect your health, it's also going to affect your Parkinson's. So does stress, by the way. Severe stress can also make your Parkinson's worse. Now, that's not licensed to go tell your spouse, hey, you leave me alone. You're making my Parkinson's worse. Sedentary lifestyle, really is like taking poison. And also being undertreated. A lot of patients don't want to take the medication because they're worried about the side effects. Next slide. So this is just a slide showing what happens over time with people with Parkinson's, and it kind of summarizes what we've been talking about all along. But basically the point here is that over time, these side effects of the medicines and of the Parkinson's tends to pile up over time. Next slide. Who needs to know about my diagnosis? I tell people on a need-to-know basis only because, when you tell someone that you have Parkinson's, they're going to see you through a different lens. They're going to look at you differently, and they're going to treat you differently. And every time you see them at a party or down on the street, you're like, oh, how you doing? And nobody really wants that. You really don't. So unless they actually need to know, I don't recommend telling someone. Next slide. So some resources. Well, Neuro Challenge Foundation for Parkinson's disease is a wonderful resource. Parkinson's Foundation, they have a booth here. APDA, Michael J. Fox, Davis Finney Foundation, Young Onset Parkinson's Network. And there's a little known one. It's called the Northwest Parkinson's Foundation. It's more of a website that's really fantastic. If you want to write that down, it's very good. But all these websites and resources you should take advantage of. Next slide. Any diets or foods? I get this question a lot. I tell people to follow a Mediterranean diet. You can also eat antioxidant foods. Avoid drinking excessive alcohol, especially heavy liquor. It's bad for you. Take a Parkinson's medication 1 hour prior to eating. It works better that way. Avoid, a big glass of milk or dairy products. Yogurt first thing in the morning kind of kills the medication. And then we always tell people to take a B complex once a day for brain health. Next slide. There's a over-the-counter extract called Mucuna, which has actually been studied in a very small study in Italy that showed that it did help people with Parkinson's a little bit. It's unregulated. You don't know how much you're getting in it. It does contain some levodopa. So some people take it. I don't recommend it usually because we don't know what the dose is. You don't know how much you're actually getting. Next slide. Do I need physical therapy, occupational therapy, speech therapy? If you're failing in any way, yes, you do. Sometimes we preemptively. Sometimes we'll do it preemptively. And the sort of things that we have, there's big and power moves, there's Speak Out. There's this thing called a Speak Up app you can get off the Apple Store, Speak Up, and that helps you to kind of monitor your voice volume. Next slide. What's the best exercise for Parkinson's? There isn't one. We really don't know what the best exercise is. So we have 120 studies showing that exercise helps. It slows the disease. So I always tell people, do what you like to do. I can tell you to go do rock steady boxing. If you're not interested, you're not going to do it. If you like to go, walk or swim, do that. The point is to do something. Do what you like to do. Be consistent and frequent with it. frequency is important. Of course, effort is good, but the main thing is that you have a ritual, a routine. And then finally, don't overdo it. You know, I have people that'll feel good, like they'll get on their bike and go for a 3-hour bike ride, and then they're wiped out for days, So if you're feeling good, still try to limit it to an hour if you could. Next slide. What sort of planning do I need? Well, you know, you should get things in order, but that, you know, not right when you get diagnosed with Parkinson's, but eventually you are going to need to figure out things like healthcare power of attorney and financial power of attorney and things like that. Talk to your family about it. Next slide. Things to avoid. Well, if it sounds too good to be true, it probably is. Next slide. So don't go to Timbuktu to get an IV stem cells that cost $50,000 for a discount price. If you want to get into an approved stem cell trial that's at like at a Harvard or somewhere, yes, that's something you should do. Bee sting therapy, spinal injections, I don't recommend that. Your neighbor has a new magnet mat that they lay out and it cured their Parkinson's. You know, if it's not hurting you, one of my thought processes on that, if it's something that's not hurting you, I'm okay with it, but also you have to be a smart consumer and not have too much hope in things that have not been proven. Next slide. Should I get involved in a research trial? Absolutely. You know, we need people to complete these research trials because we just haven't been able to get enough people in them. Go to clinicaltrials.gov, or Michael J. Fox Foundation has something called Trial Finder, which we helped them develop a number of years ago. And you put in your characteristics and it emails you and tells you if you are good for a trial. Next slide. Okay, now it's time to play Dr. Sutherland Says, my favorite game in the whole world. Next slide. Exercise is as important as any medication we can give you. Okay? Next slide. Being sedentary is like taking poison for Parkinson's. Okay, and then finally, when you go to the occupational and speech therapist and everything, you have to do those exercises at home. They're going to be done, and it's human nature to get all gung-ho, and after a couple of weeks it kind of falls off, but you need to keep up with that. It will change your life. Next slide. And this is the latest member of the Neuro Challenge family. This is Doreen's granddaughter, Romy, my granddaughter. Thank you, guys. I appreciate you all being here. Thank you.
Let's give Dr. Sutherland another round of applause. Dr. Sutherland, thank you. And thank you for sharing that beautiful photo of your new little grandbaby, Rami. How sweet. Okay, so at this time, we are going to introduce a special video presentation by one of our sponsors today, Acadia Pharmaceuticals. So it's my pleasure to invite Tarsha Davis to the stage for a quick introduction and then a video by Acadia Pharmaceuticals.
Hi, everybody. How are you doing? It is so great to be here. My name is Tarsha Davis. I represent Acadia Pharmaceuticals. We are a small company based in San Diego, California, with a really big heart. And today, we have information back there at our table that gives you education on hallucinations and delusions. And we're about to present a video that Ryan Reynolds, anybody know Ryan Reynolds, the actor? He partnered up with our company because he had an experience with his father about 10 years ago, a little more than 10 years ago. And he felt like it was important to share his story that he and his mother and his brothers went through. So if you will, please oblige us with watching the video from Ryan Reynolds. And we appreciate you taking the time to come back and say hello to us and get some more information on hallucinations and delusions that may accompany Parkinson's disease along the course of the disease. So again, thank you for being here, and we'll let Ryan Reynolds take it away. Enjoy.
About 10 years ago, two things happened that changed my life. The first is that Deadpool got greenlit, but at exactly the same time, we lost my father to Parkinson's disease.
Jim was a good dad.
I would definitely call him a present father. Never missed a football game. I think a complicated man. My dad was a bit of a mystery to me. Basically, you sort of know what to expect from Parkinson's physically, but no one warned us about the hallucinations and delusions. Around 50% of people with Parkinson's endure this at some point. He began thinking strange things about the family and our motives, and there was just no way to talk him out of some of these things.
Jim came home from a trip, and he was convinced I'd been in the car with him, but I was not in the car. He couldn't get it out of his head. It was brutal on him and on me and the boys.
We were super worried about my mom because when your world is orbiting around somebody who is experiencing this, you feel incredibly helpless and I imagine, alone.
Yeah, and you're not just losing your partner, but you also start to lose yourself. But today, there's more help than ever, thank God.
I would have loved to have had the option to help my dad see reality a little bit more clearly. So my advice would be to visit moretoparkinsons.com. You can learn how to recognize and talk about Parkinson's-related hallucinations and delusions, and a lot of other stuff that I think families might find helpful.
Yes, yes.
Ladies and gentlemen, let's welcome, testing. Hold on one second. We got to mic Leslie up. We are getting ready to bring Leslie LeBlanc to the stage, but we have to get her mic'd up, so give us just 1 second. And she is just about ready.
I know the anticipation was killing you, right? Okay, how about we do some exercise? I am Leslie. I am one of the care advisors for Neuro Challenge. I also am a rock steady boxing instructor, so I teach at HealthFit, also at Parkinson's Place, so many of you know me. Anytime I teach a class at most places, I say you can do these exercises seated or standing. However, if you're able to stand, I would love for you to get up on your feet. If not, stay seated. I am going to get you moving no matter what. So, let me get my timer ready. This is always the nemesis. Have to have this to keep on track. All right, so we're going to do, it's called the gauntlet. So it's continuous movement for the next 5 to 6 minutes until they tell me to get off stage. We're going to start with some different exercises. Every other round is going to be marching. You can do it seated or standing. First exercise we're going to start with, see if you can reach those arms up overhead. I want you to brace those abdominal muscles, and we're going to do some big side bends. I'm just going to start my timer, and here we go. 30 seconds, nice and tall. Breathe. Reach those arms side to side. Bend at the waist, right here. Good. Keep it going. We're only 10 seconds down. We got to keep moving here. Good. How about some big smiles on those faces? Reach those arms up, big side bend. I think I'm going to lose my mic soon. Keep it going, keep it going. 5 seconds, we're going to start marching right here. Good, ready? Let's lift those feet up, move those arms. If you're staying seated, we might bring those arms up like this right in front of us. Otherwise, get those knees up in the air, swing those arms nice and tall, shoulders back, eyes looking straight ahead. You guys look great. Keep going. Come on, 10 more seconds here. Let's go. Next movement, we're going to do power-ups. How many of you know power moves? Raise of hands. It's okay if you don't. I'm going to teach you. March those feet out wide. Sit those hips back. We're going to squat down. You might hold that chair in front of you. Now stand up tall, palms forward, pull those arms back, power up nice and tall. Good, do it again. Sit that butt back. Here we go. Power up. Maybe you could say it with me. Get ready, power up. Get ready, power up. One more. Get ready, power up. We're going right back to marching. Let's go. Nice and tall, shoulders back. That's it. Swing those arms. Eyes looking right at me. Pinch those shoulder blades back. Good. Keep it moving right here. Lift those knees up. Those of you staying seated, that's it. Keep moving. You got it. 10 more seconds on this one. 5, 4, 3, 2, 1. Now we're going to reach from the ceiling to floor. Go ahead and step the feet apart. Reach those arms up as high as you can. Nice and careful. Reach down towards the floor. Maybe it's just to your knees. Maybe it's all the way to the floor and then right back up. Big reach up and overhead. Stretch the front of the body. Now stretch the backside. Reach down. Big stretch. Good. Nice deep breaths. Reach them up and reach down. One more time. Reach those arms up high. Good. Once more to the floor. You'll never guess what's next. We're marching again. Here we go. Lift those knees up. Pinch those shoulders back. Look up at me. Nobody's looking at the floor. Let's move right here. 13 more seconds. I know we need music, right? It's kind of quiet. 5 more seconds. Good. Let's work our upper back a little bit on posture. Bring your arms together like this in front. Now, can we open those arms? Squeeze those shoulder blades. Find that pinch in the middle of the back. Good. Bring them together again. Good. Open up. Find that pinch in the middle of the upper back. Good. Arms together. Open up. Squeeze those shoulder blades. This one's great for posture. Here we go. Right here. Again. 1 minute. I can do it. Here, one more. March right here. Keep it going, keep it going. I'm looking at my cheat sheet of what exercises I want to do. Nice and tall, everybody, up straight. 18 more seconds on this one. Shoulders back, eyes straight ahead. I see lots of movement. This should feel good. You've been sitting for a little bit. We know that's no good for Parkinson's, right? Gotta move. 3 seconds. All right, let's do the wave. So we're gonna reach our arms out in front, one up, one down. Wave right here. Big movements, big movements. You got it. Reach those arms. Maybe we add a little weight shift side to side. Could we do that? 10 more seconds. 5, 4, 3, 2, 1. Give me 30 more seconds of marching right here. Then you get to sit again and listen to someone else talk. All right, nice and tall. This helps wake up our brain too, right? Now we can listen better. Keep it going. 15 seconds and we're done. Right here, nice and tall. You guys are great. Even with no music, everybody's moving. I love it. 7, 6, 5, finish strong. 4, 3, 2, and 1. Excellent, excellent. Good job moving, you guys. I will see you later today for another movement break, but thank you for participating. Enjoy the rest of the expo.
How about a round of applause for Leslie? I'm sorry we had to cut just a couple minutes short, but she is going to come back. Leslie is one of our care advisors. We absolutely love her, and she is fantastic with all the things that she does. And watch out for more fitness with Leslie with us. So right now, we want to give folks an opportunity to come back into the main area, please, because we're about 3 minutes away from Dr. Robert Hauser coming to the main stage. So if you are in the exhibit hall, please make your way back into your seats because actually the exhibitors are closed right now. So if you'll please make your way back in, we're about 3 minutes from Dr. Hauser coming to the main stage. So please come find a seat.
Ladies and gentlemen, if you will please take your seats. Ladies and gentlemen, if you will please take your seats.
I'm not sure I realize the level of stage management that goes into some of these things, but it's a big operation back here. Okay, so now we are very excited to prepare to bring Dr. Robert Hauser to the stage. But first, we're going to show a video message from our presenting sponsor, Amneal Pharmaceuticals, and then we will welcome Dr. Robert Hauser, Professor of Neurology, Parkinson's Disease and Movement Disorder Center at the University of South Florida, who will be presenting on innovating Parkinson's treatment with Crexont. So first, a video introduction, and then Dr. Robert Hauser. Dr. Robert Hauser is also a member of our medical advisory committee, as is Dr. Dean Sutherland, so we're thrilled that they're both here today. So, a video presentation.
Jill, tell me about your dad.
So
Don't lie.
No, I won't. I only have good things to say.
My name is Casper. Lived in Brooklyn all my life. My family's the most important thing to me. It always was and it always will be. This is you, right?
Yeah.
That's a dynamite picture.
It is. That's one of my favorites.
I was crying in the church, but I was smiling all day. Was married 50 years to the most wonderful woman in the world. She always thought about other people first. I had it made. It's a shame she went so early. Really a shame. The Corvette was in our plans. So I talk to her every day. You want to know what I do? I don't even tell Jill. I call every morning. She says, if you want, leave your number and call back. And I leave my number and I say, please call back. I opened up my own business when I was about 20 years old, automotive business. One customer told me, you need 3 people in your life. You need a good mechanic, you need a good lawyer, and a good doctor.
I'm Dr. Jill Farmer. I am a movement disorder specialist. When I first started noticing symptoms in my dad, he was having some balance issues. It was after he had a fall at our house dancing with my younger daughter. And I said, I think you might have early Parkinson's disease.
Yeah, I know I got it, but I try to control it. It is incredible how it touches every part of your body. I get out of bed. I use the excuse I fell over something laying on the floor, but I actually fell. The lamp went down, the end table went down. I put a dent in a wall, and I couldn't get up. I could not get up for all the money in the world. That's when I say, this is getting worse.
When my dad was diagnosed and we had to come up with a treatment plan for him, I know the patient before me because it's my father. So I know all of his nuances and all of his concerns and just how compliant he would be. I chose an MAOB inhibitor, and he was doing well with that until I noticed and he noticed, or really more my mom noticed, that it wasn't holding his symptoms at bay enough. And we started him on carbidopa-levodopa immediate release. For the benefit that it was supposed to do, it helped, but it also hindered him in other ways where he didn't feel like it was managing his symptoms enough. As a doctor, patients are always asking me, what would you do if it were your family? That depends on a lot of factors, but for my dad, I chose Crexont. This is a completely unique formulation of an extended release form of carbidopa-levodopa. For my dad, Crexont delivers more good on time with less frequent dosing. I think that the pharmacology of it makes sense, and the tolerability profile of it makes it reasonable to try in almost any Parkinson's patient.
Do not take Crexont with non-selective MAO inhibitors. Crexont may cause sudden drowsiness and dizziness. Avoid driving until you know how Crexont affects you. Most common side effects are nausea and anxiety.
Cresca? Crest? Creston. Crexont.
Yeah!
Does it help me? Yes, it helps me a lot. You know, it'll give me more freedom to do things. It'll give me more confidence to do things. I used to have overabundance of confidence, you know what I mean? I wasn't no hotshot. I wasn't no wise guy because I don't like those people. I need the confidence to go out. I don't want them to know that I have the disease. I don't want them to look at me in a different way. And I don't want them to worry. If I could help somebody, just this much, if I could help them, I tell my story to everybody. Everybody.
Speak to your doctor to determine if Crexont is right for you.
Ladies and gentlemen, Dr. Robert Hauser.
Thank you so much. Thank you. Hi, everybody. Okie doke. All right. How's everybody doing? All right. Well, this year I was asked to talk about Crexont. As you just heard in that introduction, Crexont is an extended release formulation of carbidopa-levodopa. that's indicated for use in Parkinson's disease. And the title of this presentation is Next is Now, Innovating Parkinson's Treatment with Crexont, as Crexont was the most recent oral medication approved by the FDA for the treatment of Parkinson's disease. So in this presentation, we'll talk about Parkinson's disease and treatment options from a healthcare provider perspective. Wait a minute, that's me, I'll talk about it. This program is for informational purposes only, not intended to provide medical advice or care. Everybody is different, and you'll see that a lot of times in presentations. Everybody is different, that's true, but there are themes, and people have a lot of overlapping symptoms, and we'll talk about those. And for this particular presentation, I'm being compensated by Amneal, the makers of Crexont, for my time and effort in bringing you this presentation. Let's see. Ladies and gentlemen. Nope, not working. Need some help getting the slides going, please? All right, here we go. Let's try again. All right, well, they're going to work on that. Okay. There we go. Oh, well. So in the presentation, I'll help you understand the benefits and limitations of immediate release carbidopa-levodopa. Immediate release is also known as standard carbidopa-levodopa.
So you're only going backwards on one?
No, I'm pressing.
Yeah, see, this is forward. Forward back.
Okay. Immediate release carbidopa-levodopa is also known as standard or regular carbidopa-levodopa. You saw that its brand name is Cinemet. So we'll talk about the benefits and limitations of that medication. We'll discuss what makes Crexont different from other forms of oral carbidopa-levodopa. You'll learn how Crexont may help you get more good on time, and what good on time is, with less frequent dosing through the day compared to immediate release carbidopa-levodopa. And I'll show you some resources to help you start treatment with Crexont. So in Parkinson's disease, we commonly talk about the ups and downs, and we're going to talk about the ups and downs of levodopa in the blood, as well as the ups and downs of the clinical benefit, when patients are getting benefit and when not. So, Parkinson's disease is the fastest growing neurologic condition. So we really have a crisis going on. Dr. Dorsey is going to talk about some of the environmental toxins and ways to avoid them, and we really need to reduce them, and we really need additional medications, particularly to slow progression. In the United States, a person is diagnosed with Parkinson's every 6 minutes. The disease is characterized, I think everybody knows this, by a loss of dopamine neurons in the brain, and when dopamine is low, that's when people exhibit the signs of Parkinson's, slowness, stiffness, and tremor. And as I mentioned already, no two people have exactly the same symptoms, but people do have these themes. Slow and small movement, stiffness in their muscles, and tremor are all common. Okay, so did you guys know that levodopa has been the standard of care for Parkinson's since the 1970s? Raise your hand if you knew that. Okay. So back in the 1960s, investigators realized that there's a loss of dopamine neurons. And so they thought, well, if dopamine is low, what should we do? You tell me, what should we do if dopamine is low? Give dopamine. But dopamine doesn't get from the blood into the brain. So if they made a medicine of dopamine, maybe it would get absorbed from the stomach into blood, but it doesn't get from the blood to the brain. So that doesn't work. So finally, some smart investigators said, let's give the precursor of dopamine, and that's levodopa. And today we take it for granted that levodopa is a good medication for Parkinson's disease, but back then it was unclear. They gave levodopa alone, and levodopa alone, very little of it gets absorbed. So they did studies where they had Parkinson patients, they gave them levodopa, and they didn't see benefit. And the reason they didn't see benefit is because very little of it got absorbed, and a lot of it that did get absorbed was converted to dopamine in the blood. And what did I say about dopamine in the blood? It doesn't get to the brain. So there were many years where investigators were trying levodopa, and they were unable to prove that it worked. And it wasn't really until it was combined with carbidopa that it was obvious that levodopa works. What is carbidopa? Carbidopa is a medication that doesn't get into the brain, it stays in the blood, and it prevents the levodopa from being converted to dopamine in the blood. So carbidopa helps levodopa get up into the brain, and once they combined those two medications together, it was much clearer that, in fact, levodopa is a good medication to treat the motor signs of Parkinson's disease. Did you know that? No, you didn't know that story. It's very interesting. Okay, so one of the lessons there is got to stick with good ideas. All right, so the next slide talks about levodopa roller coaster up and downs with immediate release carbidopa levodopa. And again, immediate release carbidopa is the standard or regular carbidopa levodopa, and its brand name is Cinnamate. And one of the issues that we still have with that medication, even though carbidopa sends more levodopa up to the brain, levodopa is very short-lived. We talk about half-lives for people who know half-lives. Levodopa only has a half-life about 90 minutes, which means when I think of it getting absorbed, it gets absorbed from the small intestine into the blood, goes up, and then it comes down pretty quickly. And it only stays with good concentration in the therapeutic zone for about 2 hours or so. So if you look at the line that's going up and down, a person takes their carbidopa levodopa immediate release, it gets absorbed into blood, and then brain, and then it goes down, and then it only stays in that good zone for 2 hours. But people with early Parkinson's disease, we give carbidopa levodopa immediate release usually about 3 times a day, and patients tell us, hey, doc, good job, I'm taking the medication, it's helping my slow and small movement, maybe my stiffness, my tremor, and it's lasting from dose to dose. Well, wait a minute, Dr. Hauser said it only lasts in the blood about 2 hours or so. The reason in early Parkinson's disease people can take carbidopa levodopa immediate release and get a good benefit that lasts 6-7 hours is because that levodopa can get up into remaining dopamine neurons, be converted to dopamine, and then slowly released over many hours. But as time goes on and people lose more dopamine neurons, that ability to convert levodopa to dopamine, store it, and slowly release it over many hours diminishes. And then patients say, well, doc, you know, it used to last from dose to dose. I take it at 8 a.m. and 2 p.m. and it lasts those 6 hours. It used to be that way, but now it's only lasting 5 hours and the benefit wears off. And my slowness, stiffness, tremor comes back. And then if we go further out in time, they may say it only lasts 4 hours, then 3 hours. And ultimately, people and their clinical symptoms oscillate or fluctuate with that levodopa curve. Initially, they get a good benefit, lasts all day long. Later on, they may say, hey, it takes 20, 30 minutes to kick in, and maybe the benefit lasts 4 hours, then 3.5 hours. And then ultimately, people begin to say, hey, it takes a longer time to kick in, and that's more variable, and it only lasts about 2.5 hours and wears off. And that's what this slide is trying to show. It's trying to show levodopa and dopamine in the brain going up and down, but if you notice that triangle, in early disease, one way to think about it is the therapeutic zone is nice and big and wide. And as people lose more dopamine neurons, that therapeutic zone gets smaller and smaller. And when people have a little bit too little levodopa in blood and too little dopamine in the brain, they lose the benefit. And so the duration of benefit of levodopa in the formulation, carbidopa, levodopa immediate release, is shorter and shorter. The other thing that happens, and Dr. Sutherland mentioned this, is over time, people develop a sensitivity to levodopa and dopamine in the brain, such that when they're getting too much or the levels of dopamine are too high for them, they get dyskinesia, which are twisting, turning movements. How many people here get dyskinesia? A few, maybe 10%. How many people get loss of benefit from their levodopa so that the benefit wears off before the next dose kicks in? Yeah, another 10% or so. So the problem then is carbidopa levodopa immediate release only lasts a short time. Early on, the brain can compensate for that, but over time, patients begin to go up and down with the carbidopa levodopa. And I'm going to skip here and talk about this. So just so that we're all talking about the same words, off means the medication benefit has not worn off. People would come into the office, patients, and say to the doctors, hey doc, my medication benefit wears off after 3.5 hours. So off is time when the benefit of medication is worn off and people are no longer experiencing that benefit, or time when it's yet to kick in. And that makes good sense with regard to English language. And then we already talked about when a person has too much dopamine in their brain from levodopa and it's too high for them, they may get dyskinesia, that twisting turning movement. And what we want to do is get in the middle and get the good benefit that we call on time. On time is time when medication is providing benefit for slowness, stiffness, and mobility. And so we're trying to thread the needle as best we can. We want to try to avoid those fluctuations up and down and get medication to be right in the middle to provide good benefit. Now these days there's another term, and for better or for worse, I developed this term, or I wrote this in a paper 25 years ago, and it's now just caught on in the last couple of years. So on is when medication is providing benefit, but when you get too much for you, you also get twisting, turning. The benefit is still there, so patient's slowness, stiffness, tremor is still happening, but if you get too much, such that you have dyskinesia, that's not good either. So we want to be in that good on zone so that you're getting benefit for slowness, stiffness, tremor, but not getting dyskinesia that bothers you. So that's our goal, is to provide as much good on time in that target zone as possible through the day. Okay. So does that make sense? Some people say yes, so okay, we're on the right track. Okay. So how common are these fluctuations and off episodes? Well, almost half of patients taking Parkinson's medication experience off episodes within 2 to 3 years. And one of the things I find is when I try to discuss these fluctuations with on and off and dyskinesia, people who are not experiencing them are kind of bewildered. They're like, I hear all this talk about it, but I don't know what you're talking about. Well, that's good. If you're not experiencing it, it's hard to understand. But once you experience it, it's pretty easy to recognize when medication is wearing off. And early on, 2-3 years out, 50% of patients have some fluctuation, but those fluctuations are mild. As time goes on, the duration of benefit shortens, and when they're off, their symptoms come back more dramatically, more severely. And same thing once patients have dyskinesia. And by 10 years from diagnosis, almost all patients are experiencing fluctuations and dyskinesia. So we already heard about this. You're not alone with regard to Parkinson's disease. You have your care partner, you have your community, you have your doctors, you have all the therapists that work with you. You're not alone. So I've been talking about good on time, time when medication provides benefit and is not so high that it's causing dyskinesia that is troublesome to you. And there have been studies lately that look at what's the benefit, what's the actual benefit of good on time. Well, many years ago, I did a study just showing that this good on time, that's what patients say they want through the day. That's when they're getting a good response. So we want to increase that good on time through the day. And recent studies have shown that for every hour more of good on time, there's meaningful benefit, including, for example, 20% higher likelihood of being able to perform activities independently. In addition, more good on time is associated with fewer falls. It's associated with a lower likelihood of uncontrolled symptoms and fewer emergency room visits and lower likelihood of hospitalization. And also take a second to say, dyskinesia also is associated with more falls. So again, we want to get you in that good on zone through the day as much as we can and avoid these fluctuations where you're experiencing either off or dyskinesia. So you may have Parkinson's, but Parkinson's doesn't have you. Tell your doctor that you want to optimize good on time, and then let me know if he says you're crazy or not. I think movement disorder doctors clearly know that term, good on time. General neurologists, I'm not so sure. But again, if you say I want more on time without dyskinesia or more good on time, that's what you want your doctor to be shooting for. And so that brings us to Crexont, the innovation that makes Crexont unique. Okay, so as I mentioned, Crexont is an extended release formulation of carbidopa and levodopa. It's the same stuff, the same active ingredients that's in regular or standard or immediate release carbidopa levodopa, but I'll show you that it's formulated to last longer. So Crexont is indicated for the treatment of Parkinson's disease. There's a little bit of safety information here that says don't take Crexont if you're on a particular type of antidepressant called a non-selective monoamine oxidase inhibitor. These are rarely used these days, but if you are on that kind of antidepressant, your doctor should say, oh, you can't take Crexont. In fact, you can't take levodopa formulation. So if you have Parkinson's, they should really change the antidepressant so that you can take levodopa. Almost all other antidepressants can be taken with levodopa, including Crexont. All right, so what's Crexont all about? So Crexont is designed to increase levodopa levels and help them last longer. And so these come in capsules, as illustrated here, and there's two components in there. The first component is immediate release granules. These dissolve quickly to help levodopa get going to provide benefit as quickly as possible. And then there's the extended release pellets. These release levodopa slowly so that the levels last longer. Now I want to ask you a question. Where is levodopa absorbed? Somebody down here knows. It's in the small intestine. So if you just make a regular extended release pill, what happens? Well, it's got to get past the stomach and then down into the small intestine. And if you design a medication that's going to be slowly released over many, many hours, part of the problem that we have is that pill's going to keep going through your intestinal system, and it only spends a short time in that proximal small intestine right past the stomach, and then it keeps going. It goes down. So if you just make a regular slow-release levodopa, it's not going to help very much in all likelihood because it doesn't stay where the medication needs to be absorbed. And so one of the special attributes of Crexont is it has a special ingredient that helps hold it where the levodopa is absorbed. So you see here, the extended release pellets are designed to gradually release levodopa in the part of the gut where it's best absorbed. And if you look at this green ball on the right, that's the extended release pellet that is in the capsule. And so it has several layers. The outer layer is an enteric layer that helps the pill dissolve slowly. We don't want it all dissolving in the stomach. It's better if it dissolves down in the small intestine. But look at the next one. The next layer, that is the special ingredient. We call it a mucoadhesive layer, which means it helps the pellet stick in the area where levodopa is absorbed. And then there's another coat that allows the levodopa to be dissolved slowly to get absorbed into the bloodstream and ultimately the levodopa core. So again, the specialness of Crexont is it has that ingredient that helps hold the capsule or the pellet in the area of the gut where levodopa gets absorbed. Okay. So what does this mean? Well, if we look at levels of levodopa in the blood, here's what they look like. The gray is immediate release carbidopa levodopa. So notice that once patients take it at time 0, you get this rapid uptake, but also it comes back down pretty slowly. And as I said, I think of it as staying in the therapeutic zone for about 2 hours or so. So you see it goes up and down quickly. Rytary is another extended release medication. You can see it goes up like immediate release carbidopa levodopa, but it maintains those levels for a longer time. And Crexont, up top in green, you see it gets absorbed quickly, and then the levels are maintained substantially longer. It looks like in that diagram they're maintained 5, 6, 7 hours. When we did the studies looking at these medications, one of the things you can do is you can take these graphs and try and come up with a number that suggests how long those levels are maintained. And for those of you who are scientists in the audience, we talk about how long are levels maintained above half of the maximum. And so you see down the bottom there, for immediate release carbidopa levodopa in gray, those levels are sustained for about 1.9 hours. For Rytary, the levels are sustained for about 3.9 hours, and Crexont is sustained, the levels are sustained for 4.8 hours. So Crexont levodopa levels are sustained significantly longer than Rytary or immediate release carbidopa levodopa. So now do you know that levodopa is absorbed in the small intestine, not the stomach? Yes, you do. And sometimes when immediate release carbidopa levodopa dissolves in the stomach, it wears off too fast because it's not getting absorbed there. The other thing is, have you ever taken a carbidopa levodopa immediate release capsule and you don't get benefit? Anybody have that happen to them? Or it takes a long time to get absorbed. Well, there's a very famous picture that we have from a patient who had that problem, and they needed surgery. They needed GI surgery. So the patient had taken their carbidopa levodopa immediate release pills. They underwent surgery. And what happened? The pills were stuck in the stomach. They don't get absorbed in the stomach. So if your pills get stuck in the stomach, they're not going to get absorbed. So we want pills that are going to move into the small intestine, stay there, and get absorbed for as long as we can. So let's explore the benefits of Crexont. Don't take Crexont or with other levodopa preparations without consulting your doctor or healthcare provider. It has similar side effects to other Parkinson medications and other levodopa formulations. Crexont, as well as other Parkinson medications, can cause sleepiness. What I tell my patients is, if you're falling asleep at inappropriate times, like during a conversation or eating meals, we need to do something to reduce your sleepiness. Same thing if you're nodding off while driving. You should not drive if you're sleepy, and if you're nodding off while driving, we need to do something about that. Don't drive when you're sleepy. The most common side effects from Crexont are nausea and anxiety. It's important with Parkinson medications to avoid abrupt discontinuation. For almost all Parkinson medications, we want to slowly reduce them if we're going to stop them. You can take Crexont with or without food, but taking it with food may decrease or delay its effect. Consider taking the first dose of the day about 1 to 2 hours before eating. Let me ask you this. This is a challenging question. When might you want to take Crexont with food? Well, if you want to slow its absorption but make it last longer at the tail end, when would you want it to last even longer? How about at bedtime to try and help you be on when you wake up in the morning? So this is something I do with my patients. For patients who say, when I wake up in the morning, I'm slow, I'm stiff, I have tremor, we may try Crexont at bedtime and say, you know what, take it with food to make it delay a little bit in its absorption and perhaps last into the morning. So that's something you might try if you're having that problem. With regard to Crexont, you should swallow it whole. Don't chew, divide, or crush the capsules, and don't take Crexont with alcohol. So the whole idea then behind Crexont is, if it lasts longer, we'd like to achieve more good on time, also with less frequent dosing. So we did a study where patients who were on carbidopa levodopa immediate release and were having the problem of going up and down came into the study, and they were optimized on that medication and then switched over to Crexont, and then ultimately we compared patients taking Crexont or carbidopa levodopa immediate release in a blinded fashion. So they didn't know which one they were taking, and we didn't know which one they were taking. And it turned out the patients who were taking Crexont took it an average of 3 times per day, compared to the patients who were on immediate release carbidopa levodopa who were taking it 5 times per day. And even taking Crexont 3 times per day, they still experienced 30 minutes more good on time through the day. So more good on time through the day with less frequent dosing is what Crexont provided in that clinical trial. If we look at off time, time when medication is worn off or not yet kicked in, same thing, 30 minutes less off time per day with Crexont compared to immediate release carbidopa levodopa, even as it was administered on average 3 times a day compared to 5 times per day with immediate release carbidopa levodopa. Now, a lot of times when I talk about that, people will say 30 minutes, that's not very much. And I say, well, but wait a minute, don't forget, we're talking about 3 times a day versus 5 times per day, and some people may need 4 doses of Crexont per day. So we did an analysis of how much good on time does Crexont and immediate release provide per dose. And in fact, this, I think, means a lot to patients. When we talk to patients in the office, we say, how long does the medication last? And this is trying to get at that kind of answer. So what we found was when we looked at the data from the study, immediate release carbidopa levodopa provided benefit, provided good on time for just 2.2 hours per dose. Pretty darn short. And in comparison, when we looked at Crexont, how long did it provide benefit per dose or good on time per dose? 3.8 hours. So if you don't remember anything else from this talk, remember this. In the study for patients going up and down, Crexont provided over an hour and 30 minutes more good on time per dose. In other words, Crexont lasted 1.5 hours longer per dose compared to immediate release carbidopa-levodopa. And as I mentioned before, let's see, hang on a sec, let me get everything together. So one of the things that we do a lot of times is switch people from immediate release carbidopa-levodopa to Crexont or other levo formulations to Crexont. But this slide reminds me to tell you that dosing needs to be personalized. There are formulas and algorithms we use to say, okay, here's how we want you to switch over, and what we generally want to do is match the peaks of immediate release to the peaks of Crexont, because that's generally when you're best controlled. The problem is that for some patients, they need a little bit more or need a little bit less. So what we tell patients is we're going to switch you over. We think this is a dose that may do well, but you got to let us know. It may be that the formula is a little bit low for you personally, so you need to call us or contact us so we have the opportunity to change the dose. Or someone may get a few side effects or dyskinesia, in which case maybe the formula has told us to give the patient a little bit too much to begin with. You got to let us know so that we can adjust the dosing to try and get the dosing right for you to provide the most good on time through the day. Important safety information: tell your healthcare provider if you have any heart conditions. Let them know if you're experiencing hallucinations. If you experience these compulsive behaviors like gambling, sexual urges, or other intense urges, let your healthcare provider know so that they can adjust medication dosages. Also, if you have thoughts of suicide or attempted suicide, we talked about if you have increased or new dyskinesia, got to let the doctor know and they may reduce the dose. Let them know if you've had peptic ulcer or glaucoma. Let them know if you are or intend to become pregnant or are planning breastfeeding. Okay, now I want to hear this now. Did you know that Crexont is designed to stay in the optimal area of absorption longer? Do you know that now? Yes, okay. And you may not need as many doses throughout the day. How many people believe that just taking fewer doses would be a benefit? Some, okay. Interestingly, FDA doesn't like when we say we think fewer doses per day is a benefit. They say, no, we care about what the medication does, not how often patients take it. So I think that's a bit of an oversight by FDA. I think it's important. Patients tell me it's important. They'd like to take fewer doses per day. All right. And I mentioned already that your Crexont dose needs to be customized for you. We use that formula to make the switch to start Crexont, but you got to give feedback to the docs if it's not working well. Maybe the dose is too high, maybe too low, or maybe we need to move the doses closer together and go up a dose. Crexont is usually started 2 or 3 times per day. If it's not lasting from dose to dose at 3 times a day, we may go up to 4 times a day. It comes in 4 strengths. You see it has the carbidopa and the levodopa in it. We generally think in terms of levodopa dose. It comes in 140, 210, 280, and 350. It takes more Crexont levodopa to match the peak of immediate release. It's formulated differently. It doesn't go up and down as much. The same amount of levodopa in its formulation kind of doesn't go up as much but lasts longer. So to match the peaks, we often have to give a higher dose. So sometimes I'll tell patients, well, this is the dose we want you to take. And they'll say, whoa, wait a minute, that dose sounds high. It's not high. We're trying to match the peaks, but we're trying to fill in the gaps when immediate release comes down, and we need more total levodopa to do that. Side effects that we saw in the clinical trials in more than 2 patients with Crexont, switching from immediate release carbidopa-levodopa. You see here, nausea, anxiety, dizziness, dyskinesia, constipation, headache, vomiting, insomnia. Again, you got to let your healthcare provider know, and they may adjust the dose to try and resolve this. We also had patients in studies of Crexont where they knew what they were taking for over a year, and it looked like it still provided benefit through that year under study. Okay, Dr. Sutherland mentioned that there are resources out there to help you, and that's on the right here. These advocacy groups include Parkinson Foundation, American Parkinson's Association, Davis Finney Foundation, Neuro Challenge, and the PMD Alliance, so they can help you. Amneal also has a number of programs to help with cost. There's an assistance program for patients who are financially challenged, and there's also a copay savings program. Eligible commercially insured patients may qualify for a $25 copay. So, could Crexont be right for you? Well, if you need or want more good on time per day with less frequent dosing compared to immediate release carbidopa-levodopa, talk to your healthcare provider about Crexont. We talked about Crexont provides, in patients who are appropriate for clinical trials, patients who are going up and down, we showed that Crexont provides 1.5 hours more good on time per dose. Crexont in the clinical trials was generally well tolerated, and your healthcare provider will personalize your dosing. They'll start by converting based on the formula, then you need to give them feedback, and they may adjust from there. Okay, I went through these already. If you're sleepy, don't drive. Medications need to be adjusted. The most common side effects of Crexont are nausea and anxiety. Don't stop medications abruptly, and don't chew, divide, or crush the capsules, and don't take Crexont with alcohol. Okay, so levodopa is the golden oldie, and like most vintage technology, its destiny was to be improved. Crexont advances the standard of care into the next era for the Parkinson's community, and again, this is an extended release formulation that has that special part of it that helps it stay in the area where levodopa is absorbed for a longer time. So with that, I'm going to say thank you. If you think Crexont might be right for you, talk to your healthcare provider about it. Thanks, everybody.
Thank you so much, Dr. Hauser, for your presentation and everything that you do. So we all know how important medications, exercise, and overall strength is to fight this disease day in and day out. Sometimes we forget about one of the most important muscles of all, our voice. Let's give a very warm and off-key welcome to our partner in presenting our off-key chorale program in Manatee County, Lynn with Key Chorale.
Thank you. Good afternoon. I see some friends. So, Key Chorale is Sarasota's premier symphonic chorus, and we're known for innovative performances and community programs that bring people together through the power of singing. Beyond the concert stage, we run a program called the Off-Key Chorale. It's a choir for people living with PD and their care partners. Every week we gather together, not just to sing, but to breathe deeper, to sing familiar songs, and to build meaningful social connections. Each season, Key Chorale delivers 80 total sessions to over 1,000 participants. My name is Lynn Lash, and I'm a singer with the Key Chorale. I'm a retired music therapist, and I've been asked to lead the new Manatee County Off-Key Chorale on Friday mornings, and you'll be able to find more about these choirs at our Key Chorale table later. The name Off-Key Chorale is meant to be playful, because the truth is, when people sing with courage, joy, and with a sense of community, there is nothing off-key about it. In fact, it might just be some of the most important music we make together. And the best part is, every one of us can sing. So let's do a little small example of what would happen if you came to an off-key chorale rehearsal. The first thing we do are some physical exercises, for instance, and you can all do these with me. They're very, very simple. The first one would be something like pretending that you're looking at the Eiffel Tower and raising your head as high as you can, up and then down to the bottom of the tower, chin. Then we would do the word no. We would say no, this way, no. I do not want to sing today. Just kidding. We all can sing. And then we would do our, well, maybe, which is bringing your ear to your shoulder. Maybe I'll sing today. I might have some fun. And then we might progress to climbing a ladder. So we would grab a rung of the ladder and then a second rung, stretching a little bit further each time up the ladder. Make sure you don't look down. All right, that might progress into swimming in the pool. All these muscles, believe it or not, are important when we sing. So we warm everything up. Very nice. And the little shoulder rolls like this. Forward, backward, shoulder rolls. The next very important component of singing is breathing. And the breathing exercises that we teach you will help any time of day to increase your ability to take full breaths. And we do something like this. We're going to take a half a breath in, and then we're going to blow all the air out until we are out of air, and then just take as deep a breath as you can in. So here we go. Half a breath in, blow it all out till you have no air left, and then a deep breath in, and feel that breath coming in, and relax. Let's do one more of those. Half a breath in, blow all the air out, deep breath in, and blow it out. Next breathing exercise we might do together is we're going to use our hands in front of us, and we're going to, on 4 counts, as we take a breath in, we're going to raise our hands to the sky. 4 breaths, 4 seconds in, suspend it when you get to the top, and then let it out for 4. So here we go. Breathe in, 2, 3, 4. Suspend, 2, and out. 2, 3, 4. Very good. Let's try 6. We're going to go in on 6, suspend on 2, out on 6. Ready, and in. 2, 3, 4, 5, 6. Suspend, 2, out. 2, 3, 4, 5, 6. Very good. And believe it or not, I have trouble sleeping at night, and this is one of the things that I do laying in the bed to relax myself, taking a deep breath, holding it in, and then slowly letting it out. It's a very helpful breathing technique. Very good. We might do something like this. I'm going to clap a rhythm, and you're going to copy the rhythm I'm going to clap. You, listen. You. Thank you, thank you, thank you, thank you. Applause is always good. All right, the last thing I would like to do is I would like to have you sing a little song with us. Hopefully we have some words up for a little song that we probably all know very well. This is from a program that I'm currently doing right now in Manatee called Are We There Yet? Remember that? Sitting in the back of the station wagon and you drive your parents crazy. Every song in this particular curriculum that I'm doing is about a state of the United States of America. So this particular one, Deep in the Heart of Texas, I think you'll know. We're going to do it together. And I thank you very much for allowing me to present today. And we do have a table for Key Chorale. You can find more information about our choirs. Here's our starting note. Are there words up there? Thank you. Ready, and go. The stars at night are big, deep in the heart of Texas. They mighty is deep in the heart of Texas. Texas. The sage in bloom is. Concentrate on that breathing. Deep in heart of Texas reminds. Deep in the heart of Texas. Real loud on the last verse. The stars that. Listen to that. Yes. Deep in the heart of Texas. Deep in the heart of Texas. Thank you very much.
Thank you so much, Lynn. You have such a beautiful singing voice, and all of you sounded amazing too. Please remember that all the programs through Neuro Challenge Foundation, including the Off-Key Chorale, are available to you at no charge. Thank you to the generosity of our community of donors, foundations, grantors, and corporate sponsors. If you enjoyed today's presentations, please consider making a donation to Neuro Challenge by visiting our table, or you can scan the QR code right on the front of your Expo program to donate today, and we are so grateful. Thank you so much. We are now coming up on our first break. Woo! All of our amazing exhibitors are officially open, including interactive demonstrations in the sponsor hall back behind the black curtain. And if you're joining us from home, we will see you back here live at 11:55 p.m. Eastern Time. Thank you.
Ladies and gentlemen, please make your way back to your seats. Our program will resume shortly. Lunch will be served at your seat. Ladies and gentlemen, once again, if you could please make your way back to your seats. Our program is about to resume. Also, lunch will be served at your seat. Thank you.
It's almost lunchtime, everybody. I see you making your way back to your seats. That's fantastic. We have a special presentation for you as we're finishing filling the seats and getting ready to distribute the lunch. So we have our friends and partners from Supernus Pharmaceuticals. Tamina is going to come up, and she has some of their ambassadors with them. So Tamina from Supernus, come join me on stage.
Hello, everyone. You guys might recognize me from last year and every other year before then. I come to this annually. It's one of my favorite meetings. I'm in the Charlotte, North Carolina area, but I come here every year for this expo because it's amazing. I just wish we had a Neuro Challenge in the Charlotte area because I would keep them very busy. or maybe they'd keep me very busy. Today, so I'm with Supernus Pharmaceuticals, and our Parkinson's medications, I have 2 that I'm representing today. The first one is our newest one that was approved April of last year. It is called Anapco. It's a continuous subcutaneous apomorphine infusion. So it's one of the Parkinson's pumps on the market. It's a tried and true tested product, meaning it's been in existence for over 32 years in Europe, and we've had it about a year now here in the States. So it's a very good product, and I have some ambassadors with me, Joe and Sarah. I'll introduce them in a minute, but they're here from Philly, so please come to our booth and speak with them. Joe is on it, and Sarah is his wife and caregiver, so you know she's just as much a part of the journey as he is. So they're wonderful. They've actually been to this before too many times and did a presentation on Apokyn, which is the injection of the apomorphine. So Apokyn is an injection. It's like on-demand therapy. Anapco is the continuous infusion of apomorphine. So two different products, but same molecule. One's on demand, and the other one's a continuous infusion. So the Anapco that Joe is on, it just supplements his pills. He's been able to reduce his pills by about half being on the Anapco. So it's been worked really great for him just to always have that reliable, continuous on throughout the day without a lot of breakthrough offs. So it's been great, and he can't really say much. You can just say hello and ask you to step back there and talk to him. My other product is GoCovery, also another great product. It's extended release amantadine, and it is an oral therapy taken every night at bedtime, and it helps with 2 things. It's got 2 indications. One is for levodopa-induced dyskinesias, so all these off medications you guys take can cause dyskinesias. The levodopa-induced dyskinesias are what GoCovery treats, and it's the only FDA-approved anything to treat levodopa-induced dyskinesias. And it actually also has an indication for off time, so it's a dual effect. It's just a pill you take every night at bedtime, so that's also great. So I'll just let Joe and Sarah say hello, welcome them from Philly, and it's nice to meet you guys. Enjoy the program and keep coming every year, because every year there's new stuff out. Thank you.
Hi, I'm Sarah, and this is my husband, Joe. He's had Parkinson's disease for 18 years. He still works, he still drives, he still runs errands for me. His quality of life, yes. And he raises our 7 blended kids in our big blended family. Joe is doing so well because we educate ourselves. We continue to come to these kinds of things. We advocate for ourselves, I advocate for him, and we always air the dirty laundry of the disease when we are in our doctor's office. And one of the things we ask about all the time are new medications and what's in the pipeline, because these newer medications, I can honestly say I've seen over the last 10 years Joe's health actually improve. With these medications, he's been able to do what it takes, because it is a full-time job fighting this disease. I see him do his rock steady boxing. I see him lift weights for his core so he doesn't stoop over. You know, I see him ride his exercise bike. All of the hard work that it takes, the big and loud, the LSVT therapy, to keep his Parkinson's from progressing. And that is because he is taking medications that help him get there. So this is Joe. Please come see us at the booth.
Yeah, thanks for listening. The only problem with Parkinson's is I do have to run the errands. It is a problem. But I appreciate it. Just for everybody out there, just ask questions, advocate like Sarah said, and educate. And then make sure you socialize as much as you can. This disease can really isolate you, and it can put you in a hole. You got to throw vanity out the window. But just, keep socializing. There's a lot of things in the pipeline. Come see us about the Anapco pump. I've been using that since August, and I've been able to reduce a lot of my medication. So thanks for listening to us, and good luck to everybody out there.
Yep.
volunteers, let's do it. Danita and the Army, the volunteer Army, are ready to serve you lunch. So if anyone is interested in a vegetarian lunch, please raise your hand. Keep your hands up for us. That's fantastic, because the volunteers that have the vegetarian lunches are going to come to you. So just keep your hand held high for us until you receive your lunch. I know we're all ready for this part, right? Nope. What's wrong? Danita said nope, and I thought she was talking to me. Our joke in the office is she is my boss. I do listen to her. Tamina, thank you so much for bringing the ambassadors to join us. I hope everyone will take the opportunity to go and visit them when they can. I just want to say, as we're settling in for the lunch in the next part of the program, what an amazing day so far, right? Like, do y'all feel that too? Like, what an amazing day. So many great things, so many great partners and sponsors. Our presenting sponsor, AM Neal, we appreciate you, Vahid, and your team. Our friends at Acadia and Supernus, AbbVie, Observer Media Group. To the speakers, Dr. Sutherland and Dr. Robert Hauser. I mean, how fantastic, right? They come and spend their Saturday with us. And to all the community resource partners, I know you all are trying to get out and visit with them. We talked about how we have so many more this year. That's an exciting thing. And so I'm glad that you've been able to take advantage of that. And the interactive demos. Lots and lots of things out there to try out. How about scooter dudes up in the front? That's right. Like, I see some faces like, yeah, they're fantastic. So many great things happening today. That's what we talk about, is this is a day to educate, empower, be together, make new friends. Just listen to Joe talk about, don't isolate, make sure that you're staying social. All those things are incredibly important. All right, our volunteers are working their way around. So we consider this a working lunch. We're going to stay in our seats. We're going to have our lunch while we're here, because we're going to get ready for some exciting things this afternoon. We still have a couple of great speakers that are going to join us. But right now, and your trash. I'm trying to remember my housekeeping duties. The volunteers will come around and collect your trash, so you do not have to worry about getting up and finding a trash receptacle to take care of that. So just tuck it under your chair, and they'll be happy to come around and pick that up. Okay, all right, so I just got the notice that we are out of veggie lunches, so if you would still like to have, it's turkey, so the other option is turkey. So if you would like that, please keep your hand up. And anybody else that doesn't have a lunch, anybody that will enjoy a turkey, anybody that needs a turkey box lunch, please keep your hand up so the volunteers can find you. Okay, so we want to take a moment to share something exciting that's coming up on April 15th and 16th, the Giving Challenge. How many of you have ever heard of the Giving Challenge? I see some hands going up. There we go. Sarasota Community Foundation sponsors this every other year. And so from noon to noon on April 15th to 16th, you'll have a chance to make a difference for people living with Parkinson's in our community. So right now, we're thrilled to highlight a very special partnership that we have formed this year with the Sarasota Opera as part of this year's Giving Challenge. We're going to share a short video celebrating how this collaboration is bringing us more programs, services, and hope to those that we serve. So let's take a watch of this little video while you're enjoying your lunch.
You may be thinking, what does opera have to do with Parkinson's disease? Well, it turns out that music is medicine.
And the arts are therapy for both people with Parkinson's and their caregivers.
That's why we at Sarasota Opera
And at Neuro Challenge Foundation for Parkinson's
are uniting our voices this season in support of the Parkinson's community.
At Neuro Challenge Foundation, our mission is to improve the quality of life for people with Parkinson's and their caregivers today. We do that through individual care advising, education, therapeutic activities, and fun social events. Our community is known for its rich arts and culture, which we know offer therapeutic benefits to those in the Parkinson's community.
And we at Sarasota Opera are committed to inclusivity in all that we do. In fact, our mission is to entertain, enrich, educate, and inspire a love of opera in diverse communities, just as we have done for more than 60 years. We do that through world-class opera performances, community outreach, and youth opera. Our new partnership, which we're calling Voices United, is a natural fit because music and the arts make a real difference in people's lives.
That's right. In fact, participating in the arts is so beneficial that doctors now prescribe it as a part of the treatment plan for people with Parkinson's.
Attending a performance strengthens social connections and a sense of community. Experiencing music even stimulates new neural pathways in the brain.
And a night at the opera offers people with Parkinson's an escape from the challenges of their daily lives while caregivers can get some much-needed respite and restoration. Our voices are united through the power of music to benefit everyone in our community, and we hope you'll join us.
Please, be the one to support Sarasota Opera
and Neuro Challenge Foundation for Parkinson's
during this year's Giving Challenge. Thank you.
We're so proud to partner with the Sarasota Opera this year for the Giving Challenge. You do have a flyer that's in your Expo bags that talks a little bit about it. So, and you can also visit the Neuro Challenge table. We'd be happy to take any questions that you have there. So we hope that you'll feel inspired and get involved. Every gift, big or small, helps amplify the impact of our programs and keeps the support free. Every program we offer, from the education to the therapeutic programs, all the things we offer are always free of charge to those in the Parkinson's community and accessible to everyone. So thank you for being a part of today and for helping us make a difference this Giving Challenge. So have you had a chance to meet someone new today? Show of hands, have you met somebody new today? Look at the hands, that's fantastic. So we have an amazing mentorship program. That's why we've partnered with the Parkinson's Association of San Diego to offer Parkinson's Connect, a mentorship program for people with Parkinson's and their care partners. There's a great part on our website that you can learn more about our trained mentors who understand what you're going through and can offer support through encouragement, and guidance. And so to learn more, you can visit, again, our website, neurochallenge.org, or again, stop by the Neuro Challenge table and talk with the ladies. There's actually several of our mentors here today in the audience. So feel free to, mentors, to go by the Neuro Challenge table and encourage folks to come and talk with you. And at this time, I do want to mention one more thing before we skip to the next part. I want to just mention that we will have another breakout session this afternoon. So you have a speaker first. There's still a little bit more of a program, but then we're going to have another breakout session this afternoon. So as you hear that, if you're interested in going to that, you'll just want to get up and make your way outside of the exhibit hall and over into the Longboat Key Room. We'll have some volunteers to help you find the way. So just putting that out there, but we're not ready for that yet because we have an amazing speaker that's going to be up here in just a few minutes. So with this, I'm going to welcome back to the stage Leah Barber, our newest staff member, to share about our new initiative, the Parkinson's Sunshine Advocates. Leah?
Hello again. That is the first time I've heard Sunshine Advocates out loud. Yay! Dr. Dorsey's ready to speak, so I'm going to move a little bit quickly. But I wanted to just tell you a little bit about our new initiative. So when I look out in this room, I don't just see patients, caregivers, and clinicians. I see a level of resilience and grit that most people cannot even imagine. Every day, you all navigate a complex world You hunt for answers, and you manage the hurdles of this disease with incredible strength. I have spent the last 20 years of my career in health policy and legislative advocacy. And if those 2 decades have taught me anything, it's this. You all are already natural advocates. Whether you are a patient navigating a diagnosis, a care partner providing that daily strength, or a researcher hunting for a breakthrough, you have the passion. Now we would like to combine it with a collective voice that cannot be ignored. So that is why I am so honored to help launch our new initiative, the Parkinson Sunshine Advocates. So I know that legislative can be a very heavy word these days. So I want to promise you that this effort is strictly mission-driven, patient-centered, and non-partisan. This is not about divisive politics or taking sides. This is about us, our families, and our lives. In my experience, advocacy is simply a bridge. It's taking the unique insights that you have and the things that only you know and sharing them with decision makers in Tallahassee and Washington, D.C., so that they truly understand the reality of Parkinson's disease. But we are not doing this alone. To the researchers, the doctors, and the clinicians in the room, these are who we call our grass tops experts. We need you too. We need your clinical insights and your data to back up these personal journeys. In my experience, I've seen that data tells a story, but people move hearts. So your story is your superpower. Whether you're sharing a daily journey from the living room or a clinical reality from the exam room, your voice is what moves the needle. I want to also acknowledge that we know we are joining a long-standing fight, and we honor the incredible work already happening in the space. Together, we are creating a unified front that ensures our shared priorities are heard loud and clear by those who have the ability to enact change. So the Parkinson's Sunshine Advocates are here to cultivate relationships, making sure that lawmakers see us as a trusted local resource, investigating causes, which is demanding transparency on the environmental risk factors and toxins in our region, showing the realities, combining personal stories with clinical data to show the real impact of Parkinson's on our lives, and to strengthen infrastructure, building an advocacy network today that is ready for the legislative challenges of tomorrow. It's also important for you to know that we are not asking you to become lobbyists or policy experts overnight. Our team will provide you with every tool, every talking point, and every opportunity that you need to make your voice heard safely and effectively. So whether you're a patient or a caregiver or one of our clinical experts, please come see us at the Neuro Challenge table. Sign up to share your story or just learn how you can become part of this community. Let's show the world the strength and the sunshine of the Florida Parkinson's community. Thank you for your opportunity to be here today.
We are very excited about this new initiative. Leah and I actually worked together. I think I mentioned this like 20 years ago. She was the state public affairs director, and I was on the development side at March of Dimes. And so we've had the opportunity to, woohoo, I know Amy, right? Some folks that know us from back in those days. But we know how important this is, and so we want to meet with you. We want to talk with you. And so if you're interested in sharing your story and lending your voice to our new advocacy initiative, please visit the Neuro Challenge. I can't talk. I must need turkey. Who else needs lunch? I heard there were some people in the crowd that did not get lunch yet. If you have not gotten your lunch, raise your hands. Do we have anybody? Dirk hasn't gotten his lunch. Okay, raise your hand if you have not gotten lunch. The volunteers are going to make one last pass for it. And we're also going to stop collecting trash. So the volunteers are going to make one last pass for the trash as well. And then we're going to keep moving on. So come visit the table about the Parkinson Sunshine Advocates. Okay, I think that was all my housekeeping news. Raise hands. Got it? Denia's coming around. All right. So now it is my great pleasure to introduce to you Dr. Ray Dorsey, whose work is helping us better understand the likely causes of Parkinson's disease, including the role that environmental toxins play. Please join me in welcoming Dr. Ray Dorsey to discuss the Parkinson's plan, and make sure you stop by his table after his presentation to get your copy of your book signed. So, Dr. Dorsey, here you go.
Watch, Jennifer. Thank you very much. Can you guys hear me okay? Wow, that's really loud. Outstanding. So first of all, thank you very much to Jennifer and to Leah for the invitation to be here today at the country's largest Parkinson's disease Expo. So there's two good things to that. One, that you're all here. Second is that there's too many of you here. So how many of you would like to figure out why you got Parkinson's? How many people would like to learn how they could slow the rate of progression? And how many people would like to make sure that their children and grandchildren don't get the disease? So we're going to talk about, give you answers to all three of those questions over the next 20 to 30 minutes, and then hopefully leave you here feeling hopeful and maybe a little bit pissed off and thinking about ways that we can bring about the fall of Parkinson's disease. So my colleague Michael Oken and I wrote a book called The Parkinson's Plan, which is available out there, free copies. Thank you to Sue and George for their efforts distributing those. We wrote it because Parkinson's disease is one of the world's fastest growing brain diseases. When Dr. Parkinson described the condition in 1817, he said, "I'm describing something that's not been classified in the medical literature. It was not in the medical textbooks." And he described 6 people with this new condition. 200 years later, it's estimated that 6 million people had the disease. So how do you go from a disease that's not in the medical textbook, affecting 6 people on the streets of London, to one affecting 6 million people around the world and is the world's fastest growing disease? Well, our genes don't change that much in that short period of a time. They're beeping at me. And it's growing faster than aging can explain by itself. Faster than Alzheimer's disease, faster than stroke, for example. So Michael and I wanted to get to the root causes of the disease, and we think that those are in our environment, as I'll discuss with you. And we look at this graph. The most recent estimate is that nearly 12 million people have this disease worldwide as a report card. And we're failing. We're failing to protect the Parkinson's community from getting more and more people affected. There have been no major therapeutic breakthroughs for Parkinson's disease this century, and only 9% of people with Parkinson's disease see a Parkinson's specialist like Dr. Oken or me. So the status quo is not working. The status quo is not working. And Michael and I don't like to fail, and we feel an obligation to serve the Parkinson's community, and we feel an obligation to protect future generations from ever getting this terrible disease. And so we put forth in our book a plan to bring about the fall of Parkinson's disease. And there's 4 elements to that plan, P-L-A-N. The first is to prevent the disease. The first response to any crisis, whether it's an infectious disease or a fire, is to contain it. And right now we are not containing Parkinson's disease because every day, every week, every month, someone in this room is hearing about from another friend or family member who's getting diagnosed with the disease. Second, we need to learn why the disease is beginning. How many people would like to have a cure for Parkinson's? So the prerequisite for curing a disease is to know what's causing it. The prerequisite for curing a disease medically is to know what's causing it. Some of you remember peptic ulcer disease, bleeding ulcers. How many people remember bleeding ulcers? So in the 1960s, bleeding ulcers were a top 10 leading cause of death in the U.S. And they used to think that bleeding ulcers were due to stress. And they did all kinds of surgeries to help address the stomach acid that was produced. They told you to change your job or to retire. And they were wrong. Stomach ulcers are due to bacteria, and now you take an antibiotic as part of a cocktail, and my guess is no one knows anyone who's died from a bleeding ulcer in recent years. If you want to cure a disease, you must first identify its cause. If you don't, you're just guessing. And we've done enough guessing. So let's learn why the disease begins. The third element of the plan is to amplify the voices of everyone in this room. The only way that the course of diseases are largely changed when people like you make your voices heard. And that's a huge burden. It's a huge burden to be Michael J. Fox. It's a huge burden to be Brian Grant. It's a huge burden to be Davis Finney. We should applaud and support these individuals who not only bear the burden of a terrible disease, but reduce that burden for others. And when you guys make your voices heard, we can see change. I'm going to give you an example of that. And if you make your voices heard even louder, we can drive more change. And then finally, we need to navigate the new frontier of treatments. So in chapters 8 and 9 of the book, Dr. Michael Oken takes you through what are the most promising treatments in the near term, the next 5 years, including levodopa pumps, what are the most promising treatments in the midterm, and what are the most promising treatments in the long term. So many people think that Parkinson's is due to aging. How many people think that Parkinson's is some natural consequence of aging? Is that what you were taught? That's what I was taught in medical school, that Parkinson's was some combination of aging, genetic mutations, and maybe a word about pesticides. And what I was taught was largely wrong. So aging, longevity, having a long life is important. And if everyone died at 40, very, very few people would develop Parkinson's disease. Because the number of new cases with Parkinson's is extraordinarily rare before age 30. But every decade, beginning in your 30s, the risk of Parkinson's triples. And in most parts of the world, it's more common in men than women. So longevity, having a long life, is important, and you must have a sufficiently long life for the disease to become manifest, for the tremor, for the slowness of movement to become apparent. But this graph, which is a graph of the incidence, the number of new cases of Parkinson's disease, looks almost identical to that for lung cancer. How many people think that lung cancer is a natural consequence of aging? No. So lung cancer in the United States in 1900 largely just did not exist. Floridians in 1900 Florida did not have lung cancer. The leading cause of cancer death in the United States and the leading cause of cancer deaths in the world just simply did not exist. It was so rare, according to the historian Robert Proctor of Stanford University, it was considered a once-in-a-lifetime oddity. All the doctors and students would gather around when they saw a case because they thought they would never see one again. But they were wrong, because 25 years after cigarettes were introduced in the U.S. around 1900, you saw a corresponding rise in lung cancer deaths. 25 years after Americans stopped smoking in the 1970s, you see a corresponding decline in lung cancer deaths. Lung cancer, like Parkinson's disease, is associated with longevity. If everyone died at age 40, very, very, very few people would have lung cancer, because lung cancer is extraordinarily rare before age 30 or 40. It triples every decade thereafter, and is more common in men than women because more men smoke cigarettes than women. There are lots of analogies and similarities between smoking and lung cancer and the environmental causes of Parkinson's and the disease Parkinson's. The second thing I was taught was that Parkinson's is due to genetics. How many people carry a genetic cause or genetic mutation for Parkinson's? So just look around the room. How many people do not? So there's a great study led by the Parkinson's Foundation called PD Generation. It's free. Anyone with Parkinson's in the United States and many other countries can participate. It offers free genetic counseling and genetic testing to anyone with Parkinson's disease. They looked at the results for the first 8,000 participants and published this in one of the leading journals in 2024. Of those 8,000 individuals with Parkinson's disease, 13% carry a genetic cause or genetic risk factor for the disease. The most common genetic cause of Parkinson's disease are mutations in a gene called LRRK2, And the most common genetic risk factor for Parkinson's disease are mutations in a gene called GBA1. Said another way, 87% of Americans, the vast majority of Americans with the world's fastest growing brain disease, have no known genetic cause or genetic risk factor for the disease. None. Zero. For 87% of Americans, 87% of people in this room carry no known genetic cause or genetic risk factor for the disease. The principal causes of Parkinson's disease are not in our DNA, they're not in our genes, they're not in our cells, they're outside of us in our environment. Chemicals in our food, water, and air are fueling the rise of Parkinson's disease, and you're all paying a really high price for it. And so what are those chemicals? There are three big ones in the United States, and it varies by geography, it varies by country, it varies by region, it varies by even the regions that you live in Florida. The three that get me the most concerned are certain pesticides. Many pesticides work by damaging the nervous systems of insects. Many of you take antibiotics. How many people are here taking an antibiotic? And so antibiotics work by damaging the cells of bacteria, but as most of you know, there are adverse or side effects with taking an antibiotic. Perhaps not surprisingly that there might be some side effects for getting exposed to chemicals that are designed to damage the nervous system of insects. Two pesticides that really concern me, but there are others. One is called paraquat. How many know about paraquat? Wow, still not a lot of people. Paraquat, according to research done by Dr. Caroline Tanner, farmers who work with paraquat, a weed killer sprayed on fields of corn, cotton, soybeans, and grapes, is associated with a 150% increased risk of developing Parkinson's disease. My colleague, Dr. Debbie Corey-Schlecht at the University of Rochester in 1999, a generation ago, showed that laboratory animals exposed to paraquat move less, and when you look at their brains, they have the pathological features of Parkinson's disease. Paraquat's so toxic that it kills the weeds that Roundup doesn't. It's been used to commit homicide and suicide, and over 70 countries, including China, have banned the chemical. But it's allowed to be sprayed in Florida, it's allowed to be sprayed in the United States, and sprayed on fields of corn and soybeans, and the two crops that are subsidized with the most agricultural subsidies in the United States are corn and soybeans. Another pesticide is a pesticide called chlorpyrifos, which I really wasn't paying much attention to until more recently. The EPA actually banned chlorpyrifos in 2021 because it's estimated to have cost 26 million American children 17 million IQ points. So children, American children, have intellectual disabilities because of exposure to an insecticide, a pesticide. EPA banned it. The manufacturer sued successfully to overturn that ban, allowing it today, depending on the state, to be sprayed on apple orchards and on golf courses. And as many of you know, there's a recent study that I'll talk about in a second, that people who live near a golf course have an increased risk of developing Parkinson's disease. The second group of chemicals are degreasing and dry cleaning chemicals. How many people know about trichloroethylene? So this actually is what I think might be the most important cause of Parkinson's disease in the United States, along with its cousin perchloroethylene. A little chemistry lesson for you. Many of you remember water is made up of 3 atoms, H2O, 2 hydrogens, and 1 oxygen. Trichloroethylene is made up of a whopping 6 atoms, 2 carbons in black, 3 chlorine atoms in blue, hence its name trichloroethylene, and 1 hydrogen atom in white. Its dry cleaning cousin is called perchloroethylene. It's got 1 additional chlorine atom, and per just means 4. Dr. Caroline Tanner showed that people who had hobby or occupational exposure to trichloroethylene had a 500% increased risk of developing Parkinson's disease. Some of you know about Camp Lejeune. So Camp Lejeune is a Marine base in North Carolina where many Marines are trained. That Marine base was contaminated with trichloroethylene from 1953 to 1987 in its drinking water. Drs. Goldman and Tanner looked at Marines who served there. To be a Marine, generally you're healthy, you're young. The average age of the Marines in this study was 20. Some were teenagers when they were exposed. And 34 years later, these Marines, the best and brightest among us, had a 70% increased risk of developing Parkinson's disease. Perchloroethylene is still used in dry cleaning in the United States. The majority of dry cleaners in the United States, to my knowledge, continue to use it. And trichloroethylene is still used for degreasing. In 2024, the EPA banned both of these chemicals, calling for their phase out. In 2025, that ban was frozen. The fate of that ban is not clear to me. I'm optimistic that most elements will be put in place, but there might be more exceptions. And the final risk factor I worry about is air pollution, which I was surprised to find here in Bradenton, Florida, yesterday. We went to the beach, my wife and I. It was a beautiful blue ocean, or blue Gulf. But in the horizon, it wasn't a blue sky, it was a little gray. And it turns out that when you see that grayness, or in that layer of smog in Los Angeles, you're seeing little pieces of dirt and soot that are suspended in the air. And most of those pieces of dirt and soot we cough out. But some of them are really small, 1/30th the width of my hair, and they can penetrate the nerve responsible for smell hanging up in the upper nasal passages. And those pieces of dirt and soot can carry some dangerous hitchhikers: lead from leaded gasoline, iron from brakes, platinum from catalytic converters, and that can increase your risk of Parkinson's disease and likely, very likely, increase your risk of developing Alzheimer's disease. So this is a map of where paraquat is sprayed in the United States. It's sprayed, as I told you earlier, on fields of corn, soybeans, grapes, and cotton. It's sprayed throughout Florida, and it's sprayed throughout just about every state in the country. One area of the country is sprayed especially most is in the Central Valley of California, which perhaps not coincidentally has among the highest rates of Parkinson's disease. Because people like you have started making your voices heard, because people like you, including farmers from California, have sued the manufacturer for their farmers who develop Parkinson's disease from the Central Valley of California have sued the manufacturer for their toxic effects. The principal manufacturer of paraquat earlier this month announced it was going to stop producing the weed killer in June of this year. Not only does that prevent the seeds of Parkinson's disease be planted for future generations, but it also has impact for those who simply live or work near where paraquat is sprayed, have a doubling of the risk of the disease. In addition, as we'll discuss in a little bit, people who already have Parkinson's disease who are subsequent to their diagnosis exposed to pesticides have a faster rate of progression. So you want to stop getting exposed to these pesticides even if you already have Parkinson's disease, and perhaps especially if you have Parkinson's disease. In addition, because your voices are starting to be heard, 13 states, red and blue, have proposed state bans on paraquat. The United States has yet to take action to ban this weed killer, but in that vacuum, some states have started to act, but not yet Florida. Trichloroethylene, I told you, may be another important cause of Parkinson's disease. And if you're like me, you had never heard of trichloroethylene until recently. But almost all of us have been exposed to trichloroethylene. In 1970, it's estimated that 2 pounds of trichloroethylene, or TCE, were produced per person in the United States. 2 pounds of TCE per person in the United States. It's estimated that 10 million people worked with the chemical, including aircraft and jet engine mechanics, automobile workers, dry cleaners, embalmers, painters, printers, shoemakers, weapons specialists, and varnish workers, and many, many more. Almost all of us have used consumer products that have likely had trichloroethylene in them. It's found in everything from carpet cleaners. It has been found in everything from carpet cleaners to gun cleaners. It was also found in typewriter correction fluid, And if you enjoyed a cup of decaffeinated coffee in the 1970s, you might have been drinking trichloroethylene. It's also had a wide range of industrial and military uses. And because of this, you don't need to have worked with the chemical to be exposed to it. You can simply have just lived or worked or studied or gone to school near a contaminated site. Many of you know that there are Superfund sites in the United States. There are about 1,200 or so of them. These are the most toxic sites in the United States that are designated by the federal government for cleanup. Over half of these sites are contaminated with trichloroethylene or TCE, including many here in Florida. And just 20 minutes from where we're sitting here today is another contaminated site. These sites go completely under our radar screen. This is a former small machine shop operator from the 1940s that used to mill and process metals. In 1958, the factory expanded and was helping produce weapons and used large quantities of toxic solvents. In 2000, 50 years after the plant opened up, large quantities of contaminated chemicals, including TCE, were discovered at this facility. And in 2003, the environmental regulators were alerted, but many residents were not, remaining unaware of potential contamination of either drinking water or this chemical evaporating like radon from water and soil and entering people's homes and schools undetected. This is a map of air pollution in the United States from 2006. Particulate matter is just a fancy scientific term for those little pieces of dirt and soot. And you can see a map of where air pollution is greatest. And then on the right is a map from Dr. Allison Willis and colleagues showing where the rates of Parkinson's disease are as highest. You can make your own determination as whether you see a relationship. Dr. Brittany Krzyzanowski and Dr. Brad Reset from the Barrow Neurological Institute in Phoenix show that there is actually indeed a relationship. Areas of the country with higher levels of air pollution are more likely to have higher rates of Parkinson's. So what can we do now that we know what some of the most likely causes of the disease are? So our book gives you an action plan, and it gives you the Parkinson's prevention pyramid. What are actions that we can take as individuals to reduce our risk of exposure to these toxicants? Because if you stop getting exposed to these chemicals, you may be able to slow your progression of the disease. If you stop getting exposed to these chemicals, you may be able to slow your progression of the disease. Indeed, for almost every other chronic condition, that's the case. If you're a smoker and you're diagnosed with lung cancer, the doctor's going to tell you to quit smoking. If you're diagnosed with high blood pressure, the doctor's going to tell you to reduce your salt intake. If you're diagnosed with type 2 diabetes, you're going to be told to change your diet and exercise. So why isn't the same thing when you're diagnosed with Parkinson's disease? Why aren't people told to stop getting exposed to pesticides, to put a water filter, if they have a well water, to put a water filter on it and to test their water? If they live in an area of the country with high levels of air pollution, to get an air purifier and close their windows or roll up their windows when they're in traffic. And in our book, we give you 25 actions you can take in your everyday life to reduce your risk of getting exposed to these chemicals, so you heighten your chance for a slower rate of progression. And these same actions your children and grandchildren can take, because we increasingly know that the seeds of Parkinson's disease are planted early. Just like in that Camp Lejeune study, the Marines weren't 60 years old when they were exposed to these chemicals. They were 20 years old. And it took 34 years or perhaps even longer for that disease to become apparent. So you can take actions in your life, your children's life, and your grandchildren's life to reduce your risk of Parkinson's disease. Then what can we do in our community? Well, one thing we can do in our community is give citizens the right to know if pesticides or these chemicals are being used near them. If you live near a contaminated facility, shouldn't you have the right to know that you do? Shouldn't you be notified annually if there's a threat to the water that you're drinking or the air that you're breathing? In the course of writing this book, I found that most schools in the United States, including in Florida, spray pesticides on kids' schools and playgrounds. We spray pesticides, many of which are nerve toxins, on kids' schools and playgrounds in this country, and we ask why 1 in 31 children have autism in the United States. Can you ask your school to stop spraying pesticides or to use less toxic pesticides? Kids don't mind weeds, kids play with weeds. Can we do the same for golf courses? Two of the most commonly used pesticides on golf courses in Florida and the United States, I believe, are chlorpyrifos, which I told you damages the intellectual abilities of children and kills dopamine-producing nerve cells in the lab, and a chemical called 2,4-D, which is some of you, especially those who served in Vietnam, and thank you for your service, was a component of Agent Orange. We spray a component of Agent Orange not to defeat the enemy, not for a public safety threat, not for an agricultural purpose, but so our golf courses are green. And we wonder why Parkinson's is one of the world's fastest growing brain diseases, and why 250 people are diagnosed today and 100 Americans died with the disease today. And then on a national or societal basis, we need to ban these most dangerous chemicals, and we need to stop subsidizing the use of pesticides. If these pesticides have untoward health effects, they should not be subsidized. They should at minimally be taxed. So in the book, if you don't like to read, if you're not a book person, you can just jump to page 237 of the book. Michael and I will not be offended. And you can read the Parkinson's 25. These are the 25 recommendations to help possibly slow your rate of progression or prevent the disease for your children and grandchildren or your spouse or siblings. The first one is to wash your produce, even your organic ones, because pesticides have contaminated our food supply. Remnants of pesticides are found in 20% of common foods. Organic produce, dairy products, and meat can reduce exposure, but can still have unsafe residues of pesticides. So wash your produce at least with water, and consider simple vegetable washes, vinegar, or salt solutions too. And we give you 25 of these recommendations. Consider an air purifier. You're not spraying pesticides in your home or on your yard. You're going to dry clean cautiously. If you dry clean your clothes, you're going to find a green dry cleaner. And we give you several other recommendations. Page 237, you can jump ahead. Then we need to learn more about what is causing Parkinson's disease. Out of every Parkinson's research dollar, only 2 pennies, 2 cents is spent on trying to prevent Parkinson's. There are homes that will be sold for more money in South Florida today than we as a nation spend on trying to prevent Parkinson's. Homes in South Florida, homes in New York sold for more money today than we as a country spend on trying to prevent Parkinson's disease. And the economic benefits to preventing Parkinson's disease are enormous. If that decision by the manufacturer of Paraquat only prevents 1% of Parkinson's disease, only 1% of Parkinson's disease in the United States, the economic benefit of that would be $500 million a year. Half of that to people like you who have lost wages, increased medical expenses, and caregiver support and time. Half of it to Medicare, which pays for the vast majority of medical care associated with people with Parkinson's disease. That $500 million is more than the estimated global sales of Paraquat according to The Guardian. That is more than the Michael J. Fox Foundation spends on Parkinson's research, which funds more Parkinson's research than any other organization in the world, and double what the National Institutes of Health spent on Parkinson's research in 2024. That's from just preventing 1% of Parkinson's disease. Then we need to amplify the voices of those affected. And we have seen success on this front. Candace Leitner in 1980 lost her 13-year-old daughter to a drunk driver when her 13-year-old daughter was just crossing the street outside of Sacramento, California, was struck by a drunk driver who had been arrested for drinking and driving a week earlier. In 1980, drinking and driving was legal in some states in the country. In 1980, 10,000 more people were dying from drinking and driving than in 1988, when Candace Leitner and many of you, thank you for your service, Mothers Against Drunk Driving, increased the drinking age from 18 to 21, made drinking and driving illegal in all 50 states, and dropped the blood alcohol level to 0.08. Because of MAD, because people who were most directly affected by the disease, and for people who could do nothing to bring their child back, but said, I do not want another mother, I don't want another father, I don't want another family, I don't want another school, I don't want another community to be affected by drinking and driving. Because of that, some of us are alive today. What a gift. And we don't even know who we are. Because in 1987, a group of courageous HIV activists adopted a motto of silence equals death, HIV is now at its lowest, the number of new cases of HIV is at its lowest level since 1990. Unfathomable for all of us who were alive in the 1980s that HIV would be falling. Because of their heroism, because of their voice, because of their activism, some of us in this room do not have HIV. And we don't even know who we are. Because of their heroism, the number of new cases of HIV is at its lowest levels today since 1990. Because of their heroism, because of their activism, HIV may disappear as a major clinical entity in our lifetime. Diseases are not permanent fixtures of humanity. Diseases come and diseases go. And it's time that we say goodbye to Parkinson's disease. So everyone in this room always wants to hear about new treatments, and there's lots of financial incentives to develop new treatments. Not much financial incentives to prevent the disease, but lots of financial incentives to develop new treatments. And Dr. Michael Oken takes you through what are the most promising treatments in the near term in the next 5 years, including levodopa pumps, in the midterm, including stem cell therapies, and in the long term, including tiny little nanobots that can go up and maybe clean up some of the misfolded proteins in the brains of people with Parkinson's. A year ago, because no one's focused on trying to prevent Parkinson's disease, a year ago I had the opportunity to join a new organization in New York City called the Atria Health and Research Institute. Their mission is to move healthcare from reactive sick care to proactive preventive care. In the United States, we spend 1 out of every $5 that we make as a society on sick care. It's time that we create a world where these diseases are increasingly rare instead of increasingly common. And we created what we think is the country's first center focused on the brain, the environment, to identify what are the underlying environmental causes underlying Parkinson's disease, underlying dementia with Lewy bodies, underlying progressive supranuclear palsy, MSA, Alzheimer's disease, ALS, intellectual disabilities, and brain cancer. And we want to do that by starting to measure these chemicals in our bodies, including our blood, our urine, our hair, measure these chemicals in our environment, including in our water, in our household dust, in our soil, and by investigating clusters of these diseases. If you want to help us out in this mission, you can sign up to be notified of future brain research studies that we'll be conducting. And if you want to help us support us financially or help us accelerate the time to we can precipitate the fall of Parkinson's disease, you can reach me. I'll give you my email address in a second, or you can find me. I'm not hard to find. So my email address is info@pdplan.org. And there are lots of actions that we can take as individuals to bring about the fall of Parkinson's disease. If you have not joined the PD Avengers, which is a global grassroots organization, my colleague just told me, Roger, is like mad for Parkinson's disease. If you're mad about Parkinson's disease and you want to make your voices heard, join the PD Avengers. You can go to pdavengers.com. It takes you 30 seconds to sign up. It's free. You can sign, if you're tech savvy, you can scan the QR code and sign up right now. And if you're old school, you can go to our booth and we'll help you sign up with our sign-up sheets and just give us your email address. You can sign up to be notified of our future research studies, and you can spread the word about the preventable nature of Parkinson's disease. You've all taken the time and energy to come here to this expo. You all know friends and family members who are not able to come to places like this. Please spread the word about the preventable nature of Parkinson's disease so we can give generations in the future one without it. We can advocate for getting rid of pesticides in our schools, our playgrounds, and our sports fields, and our golf courses. And if you think it's long overdue that we ban paraquat, if you think it's long overdue we ban pesticides like chlorpyrifos, which are making our kids less intelligent instead of more intelligent, then tell the EPA administrator to ban them. His name is Lee Zeldin. He works for you. His email address is zeldin.lee@epa.gov. Dear Administrator Zeldin, thank you for your service. Please ban paraquat. Please ban chlorpyrifos so future people do not get Parkinson's disease, so our Parkinson's disease can be slowed. His email address is zeldin.lee@epa.gov. So I had a nice introduction by Jennifer and Leah, and as they mentioned to you, they previously worked for the March of Dimes. How many of you worked for the March of Dimes? Anyone donate money for the March of Dimes? People donate money for the March of Dimes. So the March of Dimes, great success, right? Started in 1938. 17 years, and just 17 years after the March of Dimes began, Jonas Salk held up a vaccine in Pittsburgh that brought about the fall of polio. We live in a world largely free of polio because of the March of Dimes, because of the Rotary, and because of the actions of many people in this room. The March of Dimes was so successful that the March of Dimes doesn't even fund polio work. The March of Dimes doesn't even fund polio work. There are no polio expos in the United States. There are no polio treatment centers. There are no polio specialists. There are no polio support groups. There are no drug companies developing treatments for polio. Quite frankly, there's not even a cure for polio. There's just no polio. Almost no polio. If the March of Dimes can do that for polio in 17 years, what can the Pedia Expo, what can the Pedia Avengers, what can Bradenton, Florida, what can the state of Florida, what can the United States do for Parkinson's disease? We can bring about the fall of Parkinson's disease in our generation, just like we're seeing the fall of HIV in our generation, and we're seeing the decline in drinking and driving. We have succeeded in the past. We can succeed in the future. All it needs is your effort, your time, your energy, and your will, and we'll bring about the fall of Parkinson's disease. Thank you very much.
Wow. If that doesn't make you want to get involved in advocacy, then I seriously don't know what can. Thank you, Dr. Dorsey. So inspirational. And a lot of what he talked about, these are legislative issues. They're regulated by lawmakers. These are laws that can be changed and should be changed. So, thank you again. Okay. Woo. If you are attending the breakout session sponsored by AbbVie with Dr. Juan Ramirez Constaneda, now is the time to make your way to the Longboat Key Room. And if you're staying with us in the Center Hall, it is time for our next break. Please visit all the exhibitors, including interactive demonstrations in the sponsor hall behind the black curtain. Be sure to visit Rude Dog Boxing, Urban Polling, Rocksteady Boxing, and Exercise. We've got a lot of great demonstrations going on right now. Thank you so much.
All right, ladies and gentlemen, for the next 40 minutes, the exhibits are open.
seated, you just lean that way. We come back to get ready, and then we rock left. Left arm up, right arm down. All right, let's do it. I want to hear you. We're going to do it 6 times, 3 to each side. This is where we say what? Get ready, rock right. Get ready, rock left. Get ready, rock right. Get ready, rock left. One more to each side. Get ready, rock right. Get ready, rock left. This is power twist. Reach the arms out. Try not to hit your neighbor. Now, when we do our twist, we're going to bring our hands to the side, clap them together. We're going to try to turn our hips. So see if you can lift that heel, okay? This is get ready. Are we ready to start this? Get ready, twist right. Get ready, twist left. Get ready, twist right. Get ready, twist left. Give me one more to each side. Get ready, twist right. Get ready, twist left. Now power step. Notice how we get this nice wide stance? This time we're going to step. So when we step to the right, you're going to lift your right foot, take a step, reach your arm. Now when we come back to get ready, don't let the feet get close, even though it's more comfortable. Keep them wide. Are we ready for this? Hands here. Get ready, step right. Get ready, step left. Get ready, step right. Get ready, step left. 2 more. Get ready, step right. Get ready, step left. Can we put them all together? Okay. Hey, all of you that are out there behind the curtain, I need you in here. Come on, guys. All right, power flow. Power up, power rock, power twist, power step. Are we ready? Get ready, power up. Get ready, rock right. Get ready, rock left. Get ready, twist right. Get ready, twist left. Get ready, step right. Get ready, step left. Ready to do it for real this time? And I want to hear you. Okay, but I need it really for real, and I need more voices. Here we go. Get ready, power up. Get ready, rock right. Get ready, rock left. Get ready, twist right. Get ready, twist left. Get ready, step right. Get ready, step left. All right, one more thing. Hopefully we get a few more people in here. Anybody know the song, like, I don't know the name of the song, but it's like Witch Doctor? Ooh, ee, ooh, ah, ah. You know what I'm talking about? All right, try to follow along. We do this in class sometimes, so some of my guys know this one. So we go ooh, ee, now clap 3 times. Ooh, ah, ah, ting, tang, walla, walla, bing, bang. Okay? Ooh, ee, ooh, ah, ah, ting, tang, walla, walla, bing, bang. Ooh, ee, ooh, ah, ah, ting, tang, walla, walla, bing, bang. Ooh, ee, ooh, ah, ah, ting, tang, walla, walla, bing, bang. More time, or are we good? Good? More or good? One more. Okay, try that one again. Ready? For those of you that didn't catch it the first time, here we go. Start slow. Ooh, ee, ooh, ah, ah, ting, tang, walla, walla, bing, bang. Ooh, ee, ooh, ah, ah, ting, tang, walla, walla, bing, bang. Let's speed it up. Ooh, ee, ooh, ah, ah, ting, tang, walla, walla, bing, bang. Ooh, ee, ooh, ah, ah, ting, tang, walla, walla, bing, bang. Ooh, ee, ooh, ah, ah, ting, tang, walla, walla, bing, bang, ooh, ee, ooh, ah, ah, ting, tang, walla, walla, bing, bang. All right, good job, guys. Have a seat. We're going to get ready for our next speaker.
Ladies and gentlemen, please take your seats. We are about to present our next speaker.
Hello. Please make your way to your seats. We have one more speaker, and you do not want to miss this. So it's hard to believe we have now, and I forgot to say thank you to Leslie. Thank you, Leslie, for getting our bodies moving. Woo! She's amazing. Isn't she amazing? So it's hard to believe we've now come to the last part of the expo today. Our next session, presented by Dr. Fleischer, will focus on practical, everyday tips to make life easier for people living with Parkinson's. Please join me in welcoming Dr. Fleischer and make your way to your seats. Thank you.
Yeah, it's great. Hi, everybody. You've made it. You've stuck it out all day, okay? You deserve the round of applause. Yes, ooh, ee, ooh, ah, ah. You deserve all of the oohs and all of the ahs, okay? You've earned them. You guys are the survivors. All right, so my name is Jory Fleischer. I am a movement disorders neurologist out of Chicago, and so I am thrilled with your weather. Thank you. And I am very happy to talk about science. I'm very happy to show you data, and that is not what we are doing at the end of the day today, okay? What I hope for is usually what we don't want in a talk. When I give talks to medical students and residents, we joke about the eyes to phone ratio, right? We want eyes up. We don't want people hunched over and looking at their phones. But for this talk, I'm going to trust you that it's okay if your eyes are down looking at your phone. I'm assuming you're looking for one of the things that I'm telling you about, okay? So I love giving this talk because I can take zero credit for it. Everything that I tell you has almost inevitably come from a person with Parkinson's or a family member to a loved one with Parkinson's or a related disorder who said, "Do you know what I figured out the other day? Do you know about this gizmo? Or have you tried doing this thing?" And they're brilliant, brilliant ideas. These are things that you would only know if you are living with this. So I'm really excited to share these tips and tricks with you. And then if you have some, folks on YouTube, feel free, throw them in the comments. But please, please, please turn to your neighbor, share some tip or trick that you know of. So with that, all right, we're going to do a quick run through of all of the things. So I'm going to try to cover handwriting, making your smartphone work for you instead of vice versa, food preparation, eating, hydrating, dressing, footwear, hygiene, toileting, orthostatic hypotension when you stand up too quickly and your blood pressure falls, and hopefully you don't either, and then transfers, mobility, and getting out and about. And the reason for doing all of these things is these are the things that we do every single day. And if we can make these things just a little bit easier, your quality of life is better. And that is my goal. So I am not the person, unfortunately, who is going to cure Parkinson's. I've broken too many pipettes. I'm not good with mice. I love trying to help people with Parkinson's find ways to make their life better right now today. So let's get started. Okay, and full disclosure, any of the products on here, no one has paid me to mention. I have probably bought them and spent my own money to see if they're really worth the hype. So I have not taken any paid endorsements. Okay, so we were just talking about this in a conference with my fellows the other day. They were really surprised that people with Parkinson's are very bothered by the fact that their handwriting has changed. And I kind of asked our fellows, I said, look at your own handwriting. Does it look like yours? What if it looked different? And your handwriting might go on a holiday card that other people can see. What if that looked different? What if you were the person that needs to sign 18 checks for your company, and you know that your employees are going to look at your signature and go, something wrong, right? It would bother you, okay? Why are we surprised by this? So a couple of really simple things. So number one, I saw that there are courses out there to help work on your handwriting. That's amazing. Go see an occupational therapist. They are phenomenal. There are troubleshooters. They can help work on handwriting. But when it comes to something like that pile of holiday cards or a pile of checks, a really simple, cheap life hack is go to your local office supply store and get one of these, I call them the Kachunka stamps. I don't know the official name, but you can practice your signature until you get one that looks like you. And then they will print it and emboss it on that stamp. And when the time comes for all of the stack of papers, you just Kachunka, 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 okay? It's the Kachunka stamp. And that way, it is your signature, but with a little bit less effort, okay? So there's less loss of something that is so personal. If you're someone who does a lot of typing, and typing is becoming more difficult, whether your tremor is getting in the way or not, there are way better dictation softwares now than there were even 5 years ago, let alone 10 years ago. So Dragon is just one example. People talk about how they have to train their Dragon. You have to train any of these programs because depending on your dialect, your accent, how quickly or slowly or softly you speak, it's not going to get everything that you say, but the more you use it, the better it will get. We use these in the office with clinic notes, and they start off terrible, and they get better if you spend time on them. So if you do a lot of typing, dictation softwares can be helpful. But I also encourage you to be creative. So I put this mouse up here because when I was in fellowship, one of my patients had the most brilliant idea. The way he got diagnosed with Parkinson's was actually through his IT department. Because he worked on a computer all day long, and he kept having broken mice. Over and over and over, the mouse stopped working and the mice were possessed, and they kept clicking on things that he didn't want to click on. And it turned out he had a tremor, and he didn't notice that tremor, and the tremor was activating his mouse all the time. So somewhere around the 5th or 6th mouse that was defunct, his IT person said, "Let me watch you use your mouse," right? They had tried to unplug it and plug it back in already. And they said, "Do you see that your finger's shaking? You might want to get that looked at, and that might be why this is going on." So hooray for that IT dude, but also the ingenuity of this person was he realized, obviously, this was not the mouse anymore, so he drilled a hole in the side of his mouse, and he bent a paper clip, and he made himself a tremor finger rest, okay? So that it caught the tremor. He could still press down if he really intended to, but that's brilliant, right? And who except someone with Parkinson's is going to think of that? So if there's something that you have that is bugging you, can you drill a hole in it somewhere, right? And whether it's a paper clip or a hanger or something, but be creative. We can find these amazing solutions just out of necessity. All right, if you have an iPhone, I know that there are similar things in Android, but I am less familiar. And every time I do this talk, they've updated something and they move it somewhere else. So it may not be exactly this. But did you know that on your smart device, there are settings to help people with tremor? So that instead of it picking up all of those extra taps, you can decrease the sensitivity and make the phone or the tablet work a little bit better for you. You can change the settings. So if you go to the settings situation, I don't want to click the wrong button. All right, I'm going to click the wrong button. You can go to settings and you can go to accessibility. And within accessibility, usually there is a touch. And if you go in there, there are all kinds of different things that you can try. So if you turn on touch accommodations, this will help you. Under touch accommodations, you can switch. So this first one, hold duration, is so that in case you accidentally tap with a tremor, hold duration, making that longer means you have to really mean it. You have to hold your finger there for longer for it to register that you're tapping or clicking on something. You can play with that and change the hold duration for longer so that it works better for you. Similarly, right underneath there should be an ignore repeat. This is meant for my tremor folks. You can get it to ignore your repeat taps. They keep adjusting these. They keep trying to make them more accessible. So if you check back in a few months, there's probably something new. Okay. Anyone like to cook? Yes, okay. There are some of my chefs. All right, so if you like to cook and you have Parkinson's, this can be similar to having the signature that looks different. Is your knife cuts are not easy the way that they used to be. You may start okay, but as you go on, things get sloppier, things get more dangerous, it gets more effortful, right? So dust off all of the random contraptions that you might have in your pantry, right, that we forgot that we bought sometime. So the food chopper, I think of this as the other Kachunka machine, right? This you put like the onion inside, you go on top, it doesn't plug into anything, you push, 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 and the little blades inside rotate around and you take it off, and boom, you've got a nice confetti of vegetables underneath. You can throw it into your soup or your salad. It's way easier and much quicker than actually cutting and chopping everything with a knife. Or dust off the Cuisinart that's in the closet and let it shred things for you. Let it chop things for you. It's a little bit of extra work, but maybe it goes in the dishwasher. When we're eating, things can get really tricky eating with Parkinson's. So a couple of really quick hacks are sometimes as we go to push something onto our plate, we might push and push off the edge of the plate. Get a plate with a rim. It doesn't have to be ugly. They have really nice rimmed plates now, and it just gives you that little bit of extra that helps. And I've had folks tell me, well, I got the plate with the rim, Jory, that's really great, but then I'm pushing, and the plate is moving around my table. Okay, silicone placemat. Put the rimmed plate on top of a silicone placemat. It does not have to be bright red. They make them in all kinds of colors and schmancy patterns. All right, but this can be really, really helpful. Also, if someone struggles with a spoon or a fork, think back to your elementary school days of spork. They actually make silverware sporks now that can be really helpful for someone who struggles with a tremor and things are falling off. So it does double duty. Instead of you having to pick up one and then the other, it can be really, really effective. Does anyone here ever struggle with a stiff neck, with a hard time bending? Yeah, I see at least a couple of hands. So someone probably paid for their child's college education with this very brilliant hack, which was to take a plastic cup and say that if you are trying to tip your head back to get the cup up like this, but you have a really stiff neck and you can't do that, it becomes really difficult to drink. We're going to talk about why hydration is important in a little bit. So they took a cup and they cut a triangle out of it to fit your nose so that you can tip the cup up and it doesn't bonk into your nose. They're called nosy cups. There are many of them. All of the online purveyors will have some version of nosy cup. It's brilliant and so stupid that it makes us all think, why did we not just cut our cup? Okay, but really, really helpful. I had a brilliant care partner tell me that her loved one struggles with cutting up a tough piece of meat or cutting up anything tough. This is a thing that we ask about in Parkinson's, that we tell our residents. It could be an early sign. How hard is it for you to use utensils? So she said, Jory, I took away his knife, and I was worried that there was a safety concern. And she goes, no, I replaced it with a pizza cutter. This is so smart, okay? So you use a fork to hold things down and a rolling pizza cutter to cut through something tough. It works really well. Go home and try it. Or a rocking knife, if you're feeling very Italian. It's called a mezzaluna. You can use this to make pesto and cut up your herbs, but it also can be really helpful. They come in one handle or two handle, and they just rock back and forth and can cut things. So many simple things out there, and they don't look like therapeutic utensils. They look like nice utensils. Speaking of utensils, we know that weighted utensils can help dampen a tremor. And the old weighted utensils looked like your occupational therapist gave them to you, okay? And if this doesn't bother you, that's awesome. But they make weighted utensils now that look like regular utensils. You can bring them with you to a restaurant. If you are worried about going and shaking with your tremor as you're having soup at a restaurant, you could bring your own utensils with you. You have to remember and not leave them there. Otherwise, that is quite the tip that you've left for the waiter. But they can be really, really helpful. Similarly, opening jars and cans. There are a bunch of different options out there because this can be hard from Parkinson's. This is also hard from arthritis. So things that help make that easier, there are all kinds. And these one-touch electric can openers are different from the ones that we had at my house growing up that were under the kitchen cabinets. Did folks have those? Okay. These, you literally plonk it onto the can, and you press the button, and it just boop, 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 boops around the can, and it's not sharp. It's brilliant. I want to meet the engineer who did this. It's so cool. My kids can use it, okay? But take these little wins and use that energy for something else. Let the thing do it for you. Okay, I mentioned hydration. So, anyone in this room think they're dehydrated? I am, always. So most of us are dehydrated. If we wait for our thirst reflex to tell us that we're thirsty, you're way too late. You've missed the boat, okay? And this is really important for people with PD. So people with PD are both at higher risk of dehydration. Your alarm to tell you that you're thirsty is diminished. The way that your sense of smell might be diminished, think about your sense of thirst as being diminished. So it takes a lot more for us to realize that we're really thirsty. And if you are dehydrated, your risk of confusion, your risk of urinary tract infections, which is reasons 1 through 3 why people with Parkinson's wind up in the hospital, your risk of urinary tract infections goes up tremendously. Your risk of fatigue, of lightheadedness, going from sitting after a whole day of stuff. When you stand up in here, I don't want anyone passing out. Get your bottle of water. Falls and constipation. If you are dehydrated, the constipation is going to be so much worse. So we need to get water in, okay? But I am not a good plain water drinker, okay? I won't ask you to raise your hands. So we can zhuzh it up. We can make it exciting. You have my permission. It does not have to be plain water to count as hydrating. So you can make spa water, you can put cucumbers, you can put fruit in it, you can do whatever you want. As long as something is decaffeinated, it counts towards your water. Someone is going to ask, how much water should I have? It's a little bit different based on everyone's body type, but roughly 64 ounces. 8 8-ounce glasses. That does not mean I remember pouring myself 8 glasses today, but I've left them somewhere around the house in various states of finishing, right? That means actually consuming 64 ounces of fluid. But did you know that most fruit, bananas aside, are at least 90% water? So if you had that apple in your lunch today, you're good. Count that for about 6 ounces, okay? If you had some decaf coffee, that counts. Coffee's okay, it's just dehydrating. So if you drink 8 ounces of coffee, you pee out about 10. So you put yourself a little bit in the hole. No one is taking away anyone's coffee. No one is taking away anyone's coffee, but you just need to make up for it with extra fluid, okay? There are all kinds of things. You can put drops, you can put flavor powders, you can put all of that stuff. Yes, we don't love that they're artificial chemicals, but the up versus down of it is if it gets you to drink the water you need, okay. That's really what we want, all right? And find a water bottle. Find your Prince and the Frog situation of water bottle. You have to try a lot of water bottles before you find the one that's the right fit, that has the right sipping, that has the right volume for you, okay? Go to your local elementary school, tell them you have a grandchild there, and go to the Lost and Found. They have all the water bottles. That's where they are, okay? So just grab a few. They're not going to be picked up, I promise you. You can get all of my children's ones. We've never found them, but they're all there, right? So go find a bunch of water bottles, try them, find the one that you like, and then use that, okay? It really makes a huge difference. All right, here is your term, adaptive clothing. This is a term that didn't exist like 20 years ago. Adaptive clothing. Go to any store website that you like and type in adaptive clothing. JCPenney has this. Target and Amazon have this. Tommy Bahama has this, speaking of nice little Hawaiian shirts and things like this. So there are all kinds of ways that we can make it easier to get dressed in the morning. We know that this is something that takes people 2 or 3 times as long. That is not how we want you spending your day, is just stressing out about getting dressed. Get dressed and move on. We want you doing things during your day, okay? So there is a brilliant company started by a woman whose husband had early onset Parkinson's. She started this company called Magna Ready. And she realized that her husband, I think, was working as a coach in high school. And he would finish a game and he would need to quickly change and put on a button-down shirt. And he had early onset Parkinson's, and he really struggled with those little cuff buttons and the collar buttons. They're impossible. And so she was a seamstress, I believe, and she figured out a way. She sewed the buttons into the placket, that's what it's called, and she sewed teeny tiny powerful magnets inside behind them. So the shirt looks like a regular button-down shirt, but boop, closes with magnets. It's brilliant. And now they used to only have like 3 styles and they're only men. They've got women's stuff and there are copycat companies galore, which is great for us, maybe not for her. Because it means you can look at all kinds of things. There are polo shirts. Sometimes Costco has these. That's how we know that it's mainstream, okay? You can find things that close with magnet closures and take some of that struggle out of getting dressed in the morning. If you struggle with putting on socks, I challenge you, go to Amazon, type in sock device, sock aid. There are like 15,000 answers that you're gonna get. I don't know if anyone is better than the other, but you don't need to struggle putting on socks. Also, please, 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 this is your public service announcement. You no longer need to stand up to put your pants on, okay? You have my permission, MD, MSCE. You may sit down to do one leg at a time and then stand up and do all of your balance exercises, okay? But we don't use all of our good principles that we've learned in physical therapy first thing in the morning when we're putting our pants on, and that's when my people fall. So please, pants first, then balance exercises. Okay, here are, so since Costco and JCPenney got into the mix, then there are like high fashion companies that got into the mix of making adaptive clothing, which is amazing for people with Parkinson's. It's also amazing for people living with all kinds of disabilities, older, younger, across the entire spectrum. So these are just examples. Okay, going from our clothing to our footwear. Number 1, please do not show up to your movement disorders neurologist wearing heels like this. I'm gonna be concerned. I've had people in stilettos and they're going, I'm falling, I think it's my meds. And I went, well, that could be, but like, did you see me walk up the stairs? I almost fell and I don't have an excuse. Reasonable footwear is really important. Part of that is flip-flops can be really, really hard for people with Parkinson's. It also can be really hard because of the toe curling. But slip-on shoes, if we're someone where we shuffle, slip-on shoes can often be worse because we may slip right out of them. So shoes with a back, shoes that are supportive are really important. But do you need to bend down anymore to put shoes on that are supportive? Nope. Every company has. Okay, a couple of other quick things, thinking about what else do we do first thing in the morning. So maybe you're shaving first thing in the morning. It's to do it for someone else, and it has a built-in, no need for water, kind of shave moisturizing lotion, and it's all sort of there in one. So people are trying to come up with better things. If you're washing your face, we know that washcloths can get kind of cruddy and mildewy, and that's not always great. There are these like face scrubbers. It's the same kind of principle as the analog razor versus electric. Let the machine do some of that work for you and make life a little bit easier. There's a makeup artist who had Parkinson's, and she was bothered by the fact that she couldn't get a crisp line on her eyeliner. And so she tried all the products and she couldn't find something, so she made it herself. There are so many examples of this out there. So if that is something that you need help with, know that there are products out there that can actually help make that easier for you. All right, do we know that people with Parkinson's have a higher risk of dental disease? Yes, we do. Okay, so dental hygiene is even more important than someone sitting next to you who doesn't have Parkinson's. We don't fully understand yet, is it this gut microbiome? Is it that we have different bacteria in our mouth than someone without Parkinson's? We don't know. Is it the pesticides? Is it all this stuff? We don't know yet. But what we know right now that you can act on today is that you do have a higher risk of tooth decay and cavities. So seeing your dentist, and if your dentist is scared off by you having Parkinson's, it is time to find a new dentist. You need someone who feels confident taking care of you, okay? But brushing your teeth at least twice a day, flossing, and the dentist will tell you, Parkinson's or not, that an electric toothbrush will give you a better clean for the most part. It's the same principle as the razor. Let the machine do the work so that you don't have to worry about tiny repetitive movements that can get really effortful in PD. If someone is getting really dry mouth, on the right side, at least of my screen, are these little multicolored oral sponges. Those can be really, really helpful if someone has dry mouth. If flossing, the dexterity of flossing is difficult, all these little mini flossers that are pre-threaded for you are a little bit easier to use. And another dry mouth solution that a patient told me about is they were like, oh, well, when my mouth is dry, I just use ice chips. And I'm like, okay. And they're like, no ice chips? You've heard of them? And I was like ice? I've heard of them. I'm blonde, but I know ice. And they were like, no, it comes in a tin. And I was like, I don't know where you get your ice. Mine does not come in a tin. So I finally understood what they were putting down, and there is a company. It's made out of xylitol, which is an artificial sugar. It does not harm your teeth, and it's hydrating. So if you have really bad dry mouth, this is another option. Okay, so I have done over, conservatively, like 800 home visits in the homes of people living with advanced Parkinson's disease. One of the places, the room where people fall the most, is in their bathroom in the middle of the night. Night lights, please. Motion sensing night lights, please, okay? But people fall in the shower. And people often fall in the shower and say, yeah, I know I should have a shower chair, but my shower, I've seen so many showers. I've seen the tiniest ones. I did home visits in New York City. You've never seen showers. They shouldn't qualify as showers, okay? It's like, right? You can find a shower chair that fits in even a New York City bathroom shower. There are all kinds of shower benches and shower stools, right? Sitting down in the shower where we're likely to slip, to fall, and anything we hit is going to be hard. I'm going to speak on behalf of all of my movement disorder colleagues around the world. We do not want you falling in the shower. So if that means sitting on a shower chair and using a handheld shower thing, which is easily installed, using one of these long-handled bath sponges, so much better. Do not prove yourself by standing up in the shower. Prove yourself by doing your exercise, not in the shower, okay? And a lot of times I hear from people that they have a really hard time stepping over the lip of the shower, right? So the place where people have freezing of gait, where we stop and we do the little stutter steps, is at transitions, crossing over thresholds, changes in flooring, and getting into the shower is one of those most common spots. So a very simple trick is to trick your brain by taking a colored piece of non-skid tape. You can look up bathroom non-skid stickers or tape it over, and instead of thinking, I need to get into the shower, but I'm stuck, I'm just gonna step on the blue. And like, is that the same thing? Yeah, it's the same thing. We're doing the same anywhere in the house that a person with Parkinson's might go from their bed to the bathroom or in the middle of the night. We know that from their bed to the bathroom or in the middle of the night. We know that vision changes are part of Parkinson's. We know that the way that your brain interprets visual stimuli is affected, especially in darkness, and especially at night, we're more likely to be confused. So anything that gives you a little bit of light will give you a leg up and help prevent falls. Motion sensing night lights are brilliant and cheap. So line your way to the bathroom. And then, I am not gonna have you raise your hands to tell me if you are constipated, because I know the answer, okay? This is so common in Parkinson's. And just a quick shout out to any of my Jewish friends, we're about to hit Passover. It's gonna get worse, so you need to prepare, okay? Please, just take it seriously and double up the Miralax or double up whatever you are doing. It's about to get worse. All right, so very big things with constipation. I have a whole constipation talk. We're not gonna get into that today. But people have found that this is not just that everything is moving through your gut more slowly and we need more hydration and more exercise and more fiber. Yes, those are true. But also, the muscles that need to squeeze and the muscles that need to relax are getting mixed signals. And so you are pushing against a closed door a lot of the time, okay? So, very simple thing that can help is actually just elevating your feet. It changes the angle of your knees, it changes the angle of the muscles in your pelvic floor, and makes it a little bit easier to have a bowel movement. So you could get a squatty potty, which is a trademarked thing. You could get any step stool. Just put non-skid bottoms on the bottom of it so that it's not scooting away from you, okay? But elevating your feet on a step stool will help you have a bowel movement with less strain. And if we are having a hard time getting up off of the toilet, which is really common, there are all kinds of different ways. There are different seats that you can get that are raised. There are seats with bars. You do have to check the shape of your toilet seat. I did not realize that they come in multiple different shapes. There's rounder and there's oval. Get the right one that fits your toilet seat. We also know, I mentioned that the reasons 1 through 3, why my people are in the emergency room Friday afternoon and calling me is because they have a urinary tract infection, which is not going to show up as it burns when I pee, I'm going all the time, it smells different. It's going to show up as I'm falling and I wasn't before. My loved one is having hallucinations and they never have before. My tremor is so much worse and I know I took my meds. Why is everything different? Okay? If no one has told you this yet, Parkinson's moves slowly. These dopamine neurons are not unionized, okay? They don't call off work Friday at 4:30, but that is when I get all the phone calls. And it's because you're always compensating. Your brain is amazing until something else happens. And if you have a urinary tract infection, if you have COVID or the flu or anything, you're going to lose that compensation and we're going to see this sudden change in your Parkinson's symptoms. It's not the Parkinson's that changed. It's something else underneath, okay? That's when you call your doctor. That's when you go get checked. That's when you go to the ER. It's something else. The Parkinson's doesn't fall off a cliff, all right? But what can we do to prevent urinary tract infections? Hydration is number one. Hydration is huge. And then cleanliness. It can be really, really hard, especially our ladies. It's really, really hard. The dexterity to be clean is challenging as Parkinson's goes on. So you can feel very European. We can add bidets to our toilets. They've made it very easy in the last couple of years. They have all kinds of cute names. This one is Tushy, okay? So get yourself a Tushy, rent a Tushy, I don't know. But you can do this and it will help sort of prevent UTIs. Finally, in terms of the toileting things, I know it's not sexy and exciting, but if we're waking up a ton of times at night for our men, and it's hard to get back and forth to the bathroom, one of these little bedside urinals, these things that you see at the hospital, you can purchase them for cheap and keep them on your nightstand. It will save you from waking up 1,000 times. Care partners, it may save you from waking up 1,000 times. Do they tip over? Yes. Does someone forget to put the lid on? Yes. I am aware. But it's better than back and forth to the bathroom 10 times maybe. Also, yes, Depends are out there. Depends are great. Sometimes they're not all that we need. So if we need something heavier duty, these are all things that my patients have told me about. Megamax is a different kind of adult brief. Top liner boosters, someone said, you know, the briefs are okay, but my loved one goes so much at night. Even if they empty right before they go to bed, even if they do all the things and they cut off the liquids after eating dinner, we're following all the rules. But they're still having a tremendous amount of urine at night and they're soaking the bed. And I tried putting a pad inside the diaper, but the pad has a waterproof liner at the bottom. So you don't have 2 layers of stuff, you really just have 1 layer of stuff. So this top liner booster, someone found a care partner and it goes all the way through. It doesn't have a waterproof thing, so if you stick that into a Depends or into a Megamax diaper, you've got 2 layers of absorbency at night. Okay, orthostatic hypotension. So this is when we stand up, when we change positions and our blood pressure drops. So folks have shown that if you sleep at night with your head of the bed elevated, this can be really, really helpful. It actually helps reset your adrenal glands and part of the control system for keeping blood pressure okay. So if I tell people you need to sleep upright a little bit more, not fully upright, okay, we're not crazy, but like 30 degrees, 45 degrees, people go, that's okay, I sleep on 2 pillows. And I go, yeah, at the end of the night, are you here? Because everyone is there and the pillows are on the floor, right? So sleeping on a stack of pillows doesn't usually work. A bed wedge, which is this wonky triangle-shaped pillow, and you can put your pillow on top of it. Sorry. All right, so a bed wedge can be really helpful. It helps keep you upright. And the concern that people told me was, what if the bed wedge falls off? And so you can take a pool noodle. We're in Florida. In Chicago, I have to tell people to like go during like the season. But in Florida, you can find a pool noodle anywhere. Find a pool noodle, lay it down the side of your bed, put the fitted sheet over the pool noodle. You've just made yourself a Parkinson's bowling lane to sleep in. And now your bed wedge does not fall off. right? Okay, this one I came up with. I will take credit, and that is my terrible drawing. Thank you. All right, for foot cramps, someone told me that they use yoga toes. I thought that yoga toes was a particular position that I was unaware of. Yoga toes is a little silicone thing that looks like what you get when you go for a pedicure. But it's made out of silicone, and it helps prevent some of the leg cramps. The brilliant thing that a physical therapist taught me is to go to your supermarket, feel very 80s, get a Minute Maid or some other frozen concoction. Alcohol or not, you choose. Choose your own adventure. Okay? Thaw it, drink whatever's in there, and then you're going to refill it with water. You're going to keep it in your freezer. And when you have foot cramps, you are going to roll your foot over that thing. Can you do this with a tennis ball? Yes, you can. You're just missing the cold aspect. So grab whatever you've got. All right, this is the cheapest thing. You have to spend $0 on this because you have 1,000 of them in bags of bags of bags at home, right? Grab one of those plastic bags from Publix, put it on the seat before you sit down in the car. You have just taken away the friction, and you can get up and out of your seat so much easier. All right? This is the cheapest trick that I know. This works on Ubers. This works at your daughter-in-law's house with that couch that you hate because you can't get out of it. All right? This works everywhere, and you can always find a plastic bag. The more beat up, the better. There are fancy, expensive versions of this. You can buy yourself a human Lazy Susan to put in your chair, but I would advise you to just use a plastic bag. This, however, these are two really, really helpful things for driving and going to and from places. So does anyone struggle with a frozen shoulder in Parkinson's that's hard to move around? Yeah, it's one of the most common presenting signs of Parkinson's disease. So if you are in the passenger side seat and you've got a right arm that's bum, or you're a driver and you're on the left side that's bum, it's really hard to stretch it and go all the way over. And if you can't do that at all and you need your care partner to help do this for you, your care partner already has sciatica because of this. Okay, so what do? There are seatbelt extenders. They come in 2 flavors though. So if you look on Amazon for seatbelt extender, you will find one kind that is fabric, and that's for people with a larger body size to make the belt fit them. But you can also find this hard plastic kind that plugs into the existing plug and sticks it up a little bit further so you have less to reach over and buckle in. The other is this brilliant car assist handle. Again, there are hundreds of them. You can look for this, and it was designed as a very MacGyver thing, like in case you're driving through floodwaters. I don't know, this doesn't happen in Chicago, right? You're driving through the floodwaters, and you need to like bang the window open and cut yourself out of your seatbelt. You can do that with this. Cool, that is not what we're talking about. This is brilliant because you wedge it into the little latch on the side of the car door, and you give yourself leverage to get in and out. So for all of $15 and the free beat-up shopping bag, you can get in and out of the car so much easier. All right, getting in and out of bed. Very quickly, there are all kinds of different bed canes and bed handles. If you struggle to get in and out, that can be helpful. Additionally, silk or satin pajamas, or, the or is really critical here, silk or satin pajamas, or silk or satin sheets. Not and. And is a Parkinson slip and slide, okay? Pick one, please. I have had overzealous wives call me and they're like, I did both and I was like, no. And they're in the ER, okay? If your loved one is up and walking but struggling, you have probably seen gait belts from your hospital. They are these terrible things, and I still, this many years in, I cannot figure out how to weave through that terrible metal clip. They're miserable, okay? There are companies that have come up with better, waterproof, so they're safe in the shower, gait belts, and they clip with a plastic buckle like a normal thing that you can open and close. They come in different sizes. Okay, these are the last few slides. I'm sorry, guys. All right, please, as someone who takes care of folks with late-stage Parkinson's, Lewy body, I have folks in hospice. I stay on as their hospice doctor. That's my area of specialty. The only thing that I tell my residents that they are not allowed to say in my clinic is that there's nothing we can do. It's okay to not know. That's why they're learning. I'm learning stuff every day. But there is never nothing we can do. I had someone last week that said, well, we were going to go to Paris, but, and I went, yeah, well, what? Well, Parkinson's. And there are so many ways that we can get people where they want to go. It might look different. That trip might look different than it would have without Parkinson's. But that trip might look different than it would have 20 years ago, because everyone is experiencing different challenges. And there are so many things out there that can help us with mobility. So number one is this concept of energy conservation. I flew through O'Hare Airport yesterday. It is never pleasant, okay? But do I want to spend all of my energy hiking through O'Hare? Not really, but I have to, okay? If you are someone with Parkinson's, take advantage, say yes to the wheelchair. Don't spend your energy, which is a limited resource, schlepping through O'Hare Airport. Spend it when you get here, right? When you get to where you're going, when you get to be with the kids, the grandkids, wherever you're on your way to, save your energy for that, please. There is this amazing program. I did not check to see whether it's here in Bradenton, but I've seen it in so many other airports in the last few years, called Hidden Disabilities Sunflower. This is awesome. It's international. You can write to them. It's free. They will send you a schmancy lanyard like this, but it's green. It's got sunflowers. It tells people in airports all over the world that you need some extra TLC. It doesn't say why. It doesn't say what it is. It's just a silent signal to them that they should handle with care and volunteer and help just a little bit more. It's brilliant. Okay? If someone has cognitive changes or hallucinations, yes, you can still take that trip. Yes, you can still go on that cruise. Just, we might want fewer stops and a longer amount of time in one place rather than changing places every single day. That can be really, really hard to get used to and can be really disorienting. And always, 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 meds in your carry-on bag, please. People are really, really awesome at packing all the stuff that they need, and the meds get lost. And I have been the person on call over Christmas break, fielding the call from like, hi, yes, I'm in Nantucket. There's one pharmacy, and it's closing in 3 minutes, and I need you to send another one of my controlled substances. Please don't make me do that. Also, US doctors cannot prescribe outside of the country. So if you are in Mexico and you forgot your meds, it's not awesome. Okay, we can't help you. So please, please, please take extra, plan for a few extra days in case you get stuck, and bring some extra meds with you if you can. All right, transport wheelchair. Sorry, last few minutes. This is a dumb Medicare rule, but I think people don't usually know this. So this is a terrible graphic of a transport wheelchair. These are not meant for people to be spending all of their time in, okay? They are not cushy. They will give you a pressure sore if you're spending 24/7 in them. So dumb Medicare rule number one is Medicare will cover one walker and one wheelchair every 5 years. You could get a walker on Monday and decide you need a wheelchair that Wednesday, they'll pay for the wheelchair. You cannot get a wheelchair on Monday and decide you need a walker anytime in the next 5 years. Medicare won't cover it. I didn't make this rule, okay? But they don't specify which one they will pay for. So do not spend your Medicare wheelchair benefits on a transport wheelchair. Save it so that if you need a custom wheelchair, you have that benefit. They will pay for it. Those can be thousands of dollars, okay? Buy a transport chair out of pocket if you need it, or borrow one, or contact a lending closet. Don't know what a lending closet is? I'm about to tell you. All right, and if you have a transport wheelchair or your loved one is in a full-time wheelchair, this is so brilliant. This is a care partner tip. She said, do you know I was pushing my husband, we went to the zoo with the grandkids, and it was miserable. My hands are calloused. Have you tried? And I went, yeah, it's really hard. She goes, so I went to the bike store, and I told them, cut these terrible plastic things off, and I bought 2 bike handles because they're meant for outdoor use, and they're cushy and ergonomic, and he slid the new bike handles onto the wheelchair, and she didn't destroy her hands, and they could spend more time. So simple, so brilliant. Okay, so many towns, villages, municipalities have lending closets. You probably have a mini lending closet somewhere in your house where you've got one crutch left over from something, right? And the walker from Uncle Joe that's like rusted, right? So there's actually a place where you can put that stuff that doesn't have to be in your garage or your attic. You can donate it to a lending closet, and when you need something, they may have one there for you. So go online, search for lending closets, devices for, the number forthedisabled.org, I believe is national, but I could be wrong. Check out your local area agency on aging or village town hall. They can get things routed to you. Okay, so with that, I'm sorry to go so far over time. If anyone can guess what the big gulp life hack was, I would give you a prize. But thank you so much for your time and attention, and thank you for sticking it out and being here.
Fantastic. Ladies and gentlemen, a big round of applause for Dr. Fleischer. That was amazing. Dr. Fleischer, thank you so much. Some really, really great tips and tricks and hacks and all kinds of things in there, right? Ladies and gentlemen, we have made it, I'm kind of sad, I'm not going to lie, but we have made it to the very, very end of the 9th annual Parkinson's Expo. So give yourselves a big round of applause, absolutely, for being here today. We hope you have found so much information and resources and tools and all the things that can help you live well every day with Parkinson's disease, whether it's you or your care partners. We're thrilled that you have been here with us all day today. If you've been inspired by today's presentations, please consider a donation to support Neuro Challenge and all the free programs that we offer 12 months out of the year across nearly the entire state of Florida, the Southeast, across the world. You know, we've been live streamed today. Hello and goodbye to all of you who've been watching us from home all over the world today. We appreciate you. Thank you again for being here for the 9th annual Parkinson's Expo. We don't have the 10th annual date set yet, so please follow us on our YouTube channel, on our social media, on our website. If you're on our mailing list, you'll get information about that as well as soon as we choose the date and the location and all the fun details for next year. It's going to be big, guys, I promise, because it's the 10th annual. We've already started planning, so be sure to continue following us. Thank you again for being here with us. Big, big hearts to all of you for being out here with you today, to all of our volunteers, to all of the sponsors, to the staff, to every single person who helped make today possible. We appreciate you. We look forward to seeing you at another program. And if we can help, please reach out to the wonderful staff at the Neuro Challenge Foundation. Thank you, safe travels, and we will see you next year.